Good afternoon. Good afternoon. We're so glad you're here to celebrate. This is Women's Health Week from the Office of Women's Health. And I'm Kathleen Digre. I'm the director of the Center of Excellence in Women's Health here at the university. And we've been going at women's health and really working on sex and gender differences for almost 14 years. And so I'm really thrilled to have you all here. Let's see, I've got to get my slides going here. And Kate, do we have? Let's see. Okay. So this is produced by the Center of Excellence in Women's Health and supported by a lectureship fund that we have, which is housed in the Department of Obstetrics and Gynecology. And we really, our goal is to highlight the importance of sex and gender in all research here at the University of Utah. Get this thing to go forward. It's going forward on the screen. Well, as you can see, we are, and it's not going forward here, but that's okay. As you can see, we are a multidisciplinary team. We represent the School of Medicine, College of Nursing, College of Pharmacy, School of Dentistry, College of Health, Eccles Health Sciences Library, College of Social Work, Huntsman Cancer Institute, and we have several people in our group that are on main campus as well. I can get this thing to go forward. Kate, we're having trouble with the yeah. Do you want to? Do I need to do something different?
Oh, I usually ask the control down right here.
There, it's going forward now on here, but not. You have to do that. Hold that.
It doesn't extend. Make a friend for a minute. We'll just get settled.
Hopefully, we aren't going to have this trouble.
Yeah, we can call Mike back in and see.
Because I can just read from these slides too. Here, let's see if that'll go forward.
It's not showing
Well, where's the help button? I did. Okay. It's not going forward. Hey, Mike, we're not, it's not advancing.
Oh, that's not good.
Did you see it doesn't show any markers anymore?
Maybe it didn't like us. Let's do this one.
It's the introduction one.
And that's this,
Yeah.
this one, right?
Yeah.
Let's see if it's just,
Like reset it. There we go. That looks better.
let's give it a shot.
Okay, let's sit down here. Okay,
Yay.
Is it doing it?
thanks.
All right, hopefully it doesn't do it again.
All right, hopefully. Thank you, Mike. Always have some technical difficulties. Our mission for the Center of Excellence is always to think about healthcare across the lifespan for women and to try to advance in a cultural sensitive way for underserved and minority women as well. We promote research, education, and professional development. One of our signature programs, and you're going to see this in the poster, is we believe in the 7 domains of health. It's not just physical health, it's also emotional health, social health, intellectual health, environmental health, which we're going to be really stressing today, financial health, and even spiritual health. And this program does not go without a lot of team members. We have partners in Eccles Health Sciences Library. We've had a great abstract review team, and you'll notice our posters are fabulous. I do want to point out Leanne Johnston, who is actually the mastermind behind everything. She's the amazing coordinator for this meeting and almost everything we do. And Karen Schleep is the editor of the Utah Women's Health Review, and I want her to tell you a little bit about our journal and encourage you to submit.
So yeah, we have our Utah Women's Health Review. Many of you remember in 2007, this was this wonderful supplement that they had published, and then in 2019, the idea was, hey, we can make this an ongoing, publish as they are accepted. And have it every year. So since 2019, Jess Sanders was the editor in 2019, and then I took over in 2020. But we've, since our beginning, we have published 9 issues and over 200 original articles, snapshots, commentaries, or conference presentations. It's important to note that all articles have their own DOI. As soon as that is uploaded, and like I said, we publish on a rolling basis, you have something that, with its own citation. And for any manuscript, we've had at least 4 that are PubMed indexed with their own Utah Women's Health Review journal. Anything that has any kind of federal funding, of course, has to be freely available, so we can upload those, and we'll help you do that for PubMed citations. And the final thing I would just want to note is this year we launched the manuscript manager site for our journal. So this is making it really easy for both authors and reviewers to manage their submissions. And so we're really looking for both. We really want to increase our number of submissions. So we hope that any of you and all of you here would consider working with a student or yourself submitting. And then anybody who's interested in reviewing, we also need reviewers. So it's a great experience. And I've got the website here with all the information you can go to.
And Karen would love your name for reviewing, because and all 7 domains are included in the journal. We have a great program for you today. Our keynote is Dr. Lisa Larkin, who's the founder and president of Concierge Medicine in Cincinnati. She's also the president of the Menopause Society, and we're very excited about her being with us today. And our program is called Women's Health in the Crosshairs. And if any of you don't feel that women's health is not in the crosshairs, let me talk to you again, because it is. Personalized medicine is here, and there are issues with that. Environmentally, we're in the crosshairs in the state of Utah. We have mental health issues, and we have a lot of local updates for you as well. We have an amazing poster session that you have to attend. It's just phenomenal. We have 18 posters. They're terrific. And this year, thanks to Susan Schulman, who set up a fund to honor Karen Frost in the College of Social Work, we have 3 awards to give out. And we'll be giving these out after the meeting when we tally up all your votes. And you get to vote on these posters. There's QR codes for you to just, it's Qualtrics, and you just move your number 1, number 2, number 3 to the top of the list, and you get to vote on your favorite poster. I want to thank all the presenters, and then of course Leanne for all the organizational activity. And with that, I'm going to turn this over to Dr. Kirtly Parker-Jones, who's a professor emerita in the Department of Obstetrics and Gynecology, and she is going to be introducing this whole next session. And let's see, Kate, we'll get you to get everything lined up.
So you're presenting the next presenter.
I'm just introducing, so when people who are presenting, they have slides.
We don't have slides for each presenter. This is just their slides by presenter, and I can come up and get the business covers next.
Well, good afternoon. There are a number of things. Oh, well, thank you. Thank you. So to introduce our first speakers on the concept of solastalgia, I'd like to just offer you a little word. The word for the day is solastalgia. And it's a word where your heart aches for a place where you are, for what it was and it is no more. So the concept of climate grief and this solastalgia, having your heart ache for the planet, is a very real phenomenon. And I know I feel it many days. And this afternoon, we're going to be hearing from Dr. Adrienne Cachelin, who is an associate professor in the School of Environment, Society, and Sustainability. There's a whole school for those three issues, and that's terrific. Her primary research interests are rooted in environmental justice, in food sovereignty, and critical sustainability, and in pedagogy. In other words, how do we begin to teach how people can live sustainable lives? She directs the Spark Environmental Justice Lab, and she's going to be with us talking about environmental grief. And with her is Jennifer Shah. And Jennifer Shah is an associate professor in the School of Environment, Society, and Sustainability. Jennifer is a member of the Records of Environmental Disturbances, the RED Lab, and an affiliate of the Global Change and Sustainability Center, and on the steering committee for the Center for Ecological Planning and Design at the University, all are at the University of Utah. So we have two women who are thinking about big ideas about women and the environment and our hearts and how our hearts beat. So if you can come on up, maybe we can pull up your slides.
I like the maybe.
That's good.
Yeah.
That's not us. We can't talk about that. That's probably us. There we go. So we're there. Okay. And can you all hear me? I feel like oh, there we go. Now I'm in it. Well, hi, everybody. I'm Adrienne Cachelin, and this is Jen Shah. And we're, from the lower campus crowd, as we say. And yeah, the Center for, or the New School of Environment and Society and Sustainability, in case you hadn't heard of that before, is emerging in the College of Social and Behavioral Science, of Geography, and the Environmental and Sustainability Studies undergraduate program. So we're excited to have more research and teaching capacity. I'm excited to share with you today some of the things we've been thinking about climate grief and particularly women's experiences of climate anxiety and grief. We conducted this research this year with students at the U, really because we have seen so many students struggling with what is often construed as strictly bad news. I'm not going to say that climate change is good news, don't worry, but I think there are some interesting things that we'll see in these data that might be helpful. So it felt really necessary to learn more about the student experience and to think about how, it's our job to teach people about these frightening climate realities, and we don't want to hurt our students. So see if I have any more luck with this. Yeah, so there's actually 8 of us on this team of researchers, very interdisciplinary team. Jen and I, of course, and Debelina, our analysis wizard, is actually here today. Sarah Yo is from communication. And so she was really helpful in this work, as was Andrea Brunel from Geography, Lynn Zumo from the College of Education, and Monica Lohani, who is from Psychology. So quite the team of folks. Abby Nisler is one of our undergraduate students. Their honors thesis was based on some of the work that we'll be thinking about. So I I think solid stage is front and center on the slide that you will see. But this thing that we call climate anxiety and climate grief is part of this larger eco-anxiety, this idea of, again, seeing changes and feeling worry about what's going on in our environment. That can be anything from biodiversity to kind of climate issues. We also talk about ecological grief or climate grief that can show itself in a large range of emotions. And I guess, normally when we think about student anxiety or student grief, we think like, how do we make it better? Or how do we avoid having it happen altogether? How can we work with this sort of difficult task? So we started to think about it a bit more deeply and read a bit more deeply. And thinking about, of course, y'all are medical professionals, so you probably know this more than I do, but this idea that eco-anxiety and ecological grief are actually natural responses to difficult times. And there's a thing that they now call practical anxiety, meaning you're anxious about something and you do something with that. And so we're going to talk about what our students are actually doing. Similarly with climate grief, ecological anxiety or ecological grief with this climate focus. There's this great book, if you are someone who is engaging with this kind of stuff, called Not Too Late: Changing the Narrative from Despair to Possibility. And they talk a little bit about the importance of being with your grief or being with your anxiety so that you can generate things like empathy and community and the sort of the positives that come out of those really hard times. And when we think about that and we think about how this works with students, we can be thinking about when and how can we find that kind of sweet spot of grief and anxiety that brings us to a place of students really getting engaged in different ways of thinking and coping with what's really terrifying information about the climate. So some things we know that climate anxiety is prevalent among youth. I mean, they have grown up, the students we have now have grown up with this in their horizon. We also know that females are more likely to suffer from anxiety and have heightened sensitivity to these unpredictable threats. We know that females are disproportionately affected by climate change, and we know that there can be negative mental health impacts. So again, as educators, we really need to better understand what to do about instruction and recognize that it differs by gender. And that's what we found in this year of doing this work. This is a quote by Aldo Leopold. I mean, I think we often think about this stuff as fairly new, but this is from 1953, where it says, one of the penalties of an ecological education is that one lives alone in a world of wounds. He goes on to say, much of the damage inflicted on the land is quite invisible to the layman. Those were probably the good old days. But anyway, an ecologist must either harden his shell and make believe that the consequences of science are none of his business, or he must be the doctor who sees the marks of death in a community that believes itself well and does not want to be told otherwise. And I think even in that quote, we see some kinds of reckoning with this anxiety. The idea of not wanting to be told otherwise is that notion of looking away that another climate expert, Naomi Klein, talks about. How I'm sure you all have friends or maybe yourselves think, I can only read so much news in a day, and then I got to look away. So how do we cope with some of these things, and how do we move forward? That's at the core of what we wanted to find out. And with that, Jen.
Great. Thanks, Adrienne. So for this presentation, we focused on 3 research questions, although we have a broader research project on this topic, which is asking a number of additional questions. But with each of these questions, we are asking how answers to them may differ by gender. And the 3 questions include, what is the prevalence of climate anxiety amongst undergraduate students? And does that differ amongst males and females? Oops, you somehow, oh, I see. There we go, I got it. Yay. How common is climate change a concern amongst undergraduate students? And again, does that differ by gender? And finally, what are the common strategies undergraduate students use for coping with climate change? We conducted the survey using we conducted the study using a survey, which we developed in Qualtrics and had approved by the IRB. Then we distributed this survey to undergraduates in several courses throughout the fall and spring semesters of the last year. Participation was voluntary, and extra credit was given to students who completed the survey. Gender in this study was self-identified amongst several binary and non-binary options, including the opportunity to elect preferring not to say. However, in the data we're presenting today, you'll see only 2 genders are presented because the majority of responses were cisgendered. And so the limited number of alternative responses were not sufficient enough to do statistical analyses. You'll note that females represented 66% of the folks that completed the survey. Again, we're going to focus on just 3 main questions from the survey, and that include 10 statements related to climate change that helped us ascertain the prevalence of climate anxiety, 11 options of coping strategies, and for both of these questions, for the coping strategies, there's also the option to note other and give an open-ended response. Note for these 2 categories of questions, we were asking frequency of attitude about the climate statements or the frequency different coping strategies were utilized, and we used the Likert scale shown on the slide. For the last area on concerns, we asked students simply rank which concerns amongst a list of 11 options were their top 3 concerns, and climate was one of these. We then conducted a factor analysis with Verimax rotation and a test using Chromebox Alpha in our software to determine how related the climate statements were to one another, as well as, excuse me, which coping strategies were most related to one another. This allowed us to determine that actually all of the climate statements fell onto one factor. So we were able to construct an index, which I'll describe in a bit more detail in the next slide. We're calling the Climate Anxiety Index. And then second, we're able to identify 3 different factors or 3 broad coping strategy types. This slide is showing you the actual questions of climate statements related to climate anxiety. For the brevity, I won't read all of them, and nor are the individual responses detail I'd like to go into today, although the differences are important. I just want to reiterate that all of these statements fell onto one factor analysis that allowed us to sum. I'm sorry, I missed that. Okay. We took some responses from each of these statements for each respondent, and that then gave us an overall score for each individual, and that was the index per person that we utilized as our response variable in the additional analyses that I'll be showing you today. So this slide on the left is showing you a frequency distribution of our climate anxiety index. You see it's a slightly right skewed normal distribution, suggesting that the majority of students that that completed the survey have mild to moderate levels of climate anxiety. The slide on the right is comparing climate anxiety between females shown on the left and males on the right. And we see that there's strong evidence that females have greater climate anxiety than males do. This slide is now showing you our list of concerns and how students ranked them. The black bars are number 1 ranking, and then the lightest gray is the 3rd most common concern. You'll see actually that climate is not the top concern. Rather, things that are personal concerns on a daily basis ranked higher. Yet amongst all the responses, it's still 15% of students rank climate in the top 3, which is very important to point out. Also, females were more likely to rank climate in their top 3 than males were. This is showing you the different types of coping mechanisms. And we'll note that the top 3 here show that students often use recreation, self-care, some form of self-care other than recreation, or changing one's own behavior as the top 3 coping mechanisms. However, our factor analysis did indicate that we could more simplify these responses into 3 different broad categories. And those include coping that we're calling meaning-focused coping mechanisms that include volunteerism, advocacy, changing one's own behavior, encouraging others to change behavior. Then the second category is variation in self-coping, such as talking to family, recreating, engaging in self-care. And lastly, coping mechanisms related to therapeutic measures, such as going to talk to a mentor, talking to a professional therapist, or attending a support group. And you'll see that we have strong evidence for females engaging in this meaning-focused coping, advocacy, or volunteerism at a higher frequency than males. There's weak evidence for gender differences in the other 2 categories, yet it looks like the mean response is very similar between the 2 genders. I just want to talk about this therapy coping mechanism really quickly, even though we didn't see strong difference. Anecdotally, we did see that the number of students who attended good grief circles that we've been offering on campus, this is a support group for folks who are experiencing climate anxiety and grief. The attendees tended to more often be females than males. This is an incredibly great resource for students, and we're looking for more partners to offer more of these circles. And folks can get trained as facilitators through the Good Grief Network, which I have a URL listed here on the slide. And this program was developed from a graduate of the Environmental Humanities program at the University of Utah with additional partners. Just coming back quickly to, where we did see strong evidence of a meaning-focused coping, I wanted to share a few quotes from our open-ended responses from students. And one example, you can read these, but I'll just read one for you. I feel responsible to be part of a solution after learning and knowing the current social injustices surrounding climate change. So students are really trying to channel that anxiety into meaningful action. And that is supported by what we see in the literature, that, as Adrienne mentioned, anxiety and grief can be a motivator to action, and that being active can help transform anxiety to optimism, or at least somewhat more positive feelings about what's going on in the world. And with that, I'll let Adrienne close.
So we thought it seemed fitting to wrap up by thinking about women trailblazers leading the battle against climate change. These folks are government executives, CEOs, program leads. They work for NGOs, academics, they're activists. And there are a few examples from around the world, and I bet that we can all think of our own local examples as well. Probably many of you are familiar with Greta Thunberg. And again, when we think about mental health and issues around mental health, her story is a very interesting one. When she started thinking and reading about climate in like the 8 to 11-year-old phase, by 11, she stopped speaking and she stopped eating. And at 15, she decided that she was no longer going to go to school and instead do these climate strikes. And that is actually what brought her out of depression. And so a lot of authors, various folks refer to it as Greta's superpower, that she took something that was really hard and turned it into something that I think we can legitimately say is world changing. So I think we just want to leave you with this idea that, you know, while many women see the planet in the crosshairs more frequently, in terms of climate grief, they experience that and climate anxiety disproportionately. And this is true in less economically developed countries, as well as our own affluent university settings. The bright side, the good news, is that they're also more likely to cope with their climate anxiety and grief in ways that benefit us all. And for us, I think as educators, the trick is to better understand that pedagogical sweet spot where anxiety and grief can spur creative action, generate empathy, and help us be our best and happiest and most effective selves in the face of a rapidly changing climate.
Oh, shit.
Seeing as how we got a little bit of a late start, I think we can steal a few minutes for questions. Any questions? Yeah.
Thank you so much. I was wondering what your next steps are, especially related to seeing these notable differences in disposition for action plans.
Repeat the question.
Yeah.
What things can be leveraged to help reach our equipoise there?
Yeah. So the question, and help me if I didn't get it all, but the question is kind of what are the next steps? And especially in terms of thinking about the different levels of response and engaging more response. We've only just begun to look at some of these data. And another thing that we actually looked at was how much what the AAC&U, the American Association of Colleges and Universities, calls high impact practices, things like undergraduate research, things like community engaged learning, various experiential kinds of learning. We're looking at if there's a correlation between those and folks who respond more actively. And everything tells us that there should be, but we haven't gone that deeply into the data quite yet. You have anything you want to add to that?
No, but I have been asked to let you all know you have microphones in front of you, that when you ask a question, you can press the button in front of you so that we can save some time by not repeating the question. But thank you for that very good question.
Okay, well, he did ask about men and women. So the difference is how we're going to increase, not the eco-anxiety, but the engagement for men.
Yeah, I wish I knew. We'll keep looking and seeing if there, how those correlations look in terms of those impact practices and see if they differ along gender as well. I think it's interesting to note too that there were so many more women that took this study, people identified as women that participated. So that's a really interesting thing too. And one just last thing I'll throw out that I think is interesting is that when we split out environmental studies majors from there were more like 25% of folks who listed it in their top 3 concerns. So there's this moment where we know targeted education is making a difference, hopefully not to hurt people, but to engage them.
And that is another major focus of our study, is to understand how our pedagogy is affecting mental health and how we can change our pedagogy to help mitigate and alleviate climate grief, and then channel it in these productive ways.
Well, I think for those of us elders who need some help with our climate grief, I'm looking for a support group for people over 65 who just want to cry all the time. So
Please come to our Good Grief Circle. Advertise.
thank you. Well, we're going to move from the external environment to our internal environment with our next speaker, who is Brenda Heaton, who is the Associate Dean for Research and Associate Professor of Epidemiology and Health Services Research at the University of Utah School of Dentistry. She's also Adjunct Associate Professor of Population Health Sciences at the Spencer Fox Eccles School of Medicine. And Dr. Heaton is an epidemiologist whose primary research interests include a focus on the social production of oral health. And this is a new one for all of you. I'm sure this is the first lecture you've heard on the social production of oral health, and I'm really excited. I'm brushing my teeth at just thinking about it.
Well, thank you. I'm really happy to be here. I'm a little taller than everybody else. Are you picking me up? Okay, because I'd like to take a little bit of a step back. Is that okay? Okay. All right. Well, why is this titled Putting the Mouth Back in the Body? How did the mouth get out of the body in the first place? And so we have to just touch a little bit on history and the schism between medicine and dentistry. What happened? How did they get separated? How many people here have wondered why their dental insurance is separate from their medical insurance? Right? How many people know why? Well, guess what? You're gonna get to learn. So medicine, the separation of medicine and dentistry, it dates back several hundred years. In dentistry, we like to talk about Paul Revere as America's first dentist, because dentistry was practiced by blacksmiths, which is what Paul Revere apprenticed in. And it was also practiced in barber shops. In fact, if you go to the dental office, you'll never see it the same again. It looks like a barber shop, right? It's open air, multiple technicians, clinicians working on chairs, no privacy. But it was a trade. And so there was some bias and stigma associated with that. Now, dentistry was practiced by physicians, and it was even considered like a specialty in medicine. So when people showed up in a hospital and they had dental issues, physicians would treat them, but on the everyday, particularly for the lower class, it was being addressed as a trade. So when the University of Maryland proposed that a dental school or a dental specialty be introduced at the School of Medicine, it was denied. And so then started the very first dental school called the College of the Baltimore College of Dentistry in 1840. So we started this split of education. And so the education was completely separated. If we move forward into when insurance models came about, medical insurance was really focused on the catastrophic, the large, sort of unpredictable events. And dental insurance was for preventive care. It was meant to be predictable. And then when the government got involved in public insurance models, Medicaid, Medicare, the American Medical Association and the American Dental Association fought hard against that. The American Dental Association won that battle, and still to this day, dental benefits are not federally mandated as part of Medicaid, and dental benefits are not in Medicare. So states get to decide whether they have dental benefits at all, and to what extent they have dental benefits. What else can I tell you? The American Dental Association was formed in the 1800s, and it excluded any non-white dentists until 1967. And it wasn't until 2013 that there was a formal apology made for those exclusionary practices. So there are a lot of consequences that come into play, and let's talk about them. Documentation and charting. So the electronic dental record came long after the electronic health record. In fact, some of your dentists may still be using paper charts. It's still a common practice in dentistry. And what that means is coding and billing are also separate. So you see this sort of like organizational schism between medicine and dentistry. So you can't really develop clinical databases that have oral health and medical health in them. So you can learn a lot about oral health, or you can learn a lot about medical health, but you can't learn about them very well together, and you can't do good research. Population surveillance. National Health and Nutrition Examination Survey started in 1960, and Haynes. Dentistry showed up very briefly in 1970, came immediately back out, went back in 1988, came back out, and it wasn't until 1999 that it became part of the continuous population surveillance. So we haven't had a good sense of what population oral health looks like for the last centuries. And we're just starting to learn. And if you look over here, this is a diagram that I like to use that shows all of the inflammatory comorbidities that are associated with periodontal disease. that have been represented in studies. So the mouth is important to the body, but because we're not taking care of it, oral health owns the largest population disparities in health. So disparities are a very big deal in oral health. We also have really bad workforce diversity. Black men are significantly underrepresented in dentistry. In Utah, 96% of dentists are white males in Utah. So we don't have a lot of diversity, and there are impacts of that. There's also been an impact on research. So there is a dental institute, the National Institute of Dental and Craniofacial Research at the NIH, the NIDCR. It does exist. It's small. It's where I happen to get all of my funding, which is great, but it's very small by comparison. And yet we all have dentistry, right? Not a single one of us has never been to the dentist or had a dental issue that had to be addressed. So there's, Kathleen talked about women's oral health in the crosshairs. This is the crosshairs. And women get really affected and impacted by this schism between medicine and dentistry. So I just want to bring a few highlights from my own research that really are driven by this history that is so important and gives meaning to what we're seeing on a population level in terms of oral health. So what do we know about gender and race? So we know that racism or race, it's been associated with poor oral health. And we know that men and women have been shown to experience racism differently. So there's a whole body of research on that. In fact, there's a lot of research about gender and racial biases in pain management. Brave men, emotional women, right? We're hysterical, right? Too much emotion, and it's not real. Our pain is not real. African Americans, in particular, they get less aggressive pain management. And who's ever had pain at the dentist, right? Okay. So in fact, 1 in 7 is estimated, there's not good data on this, but it's estimated that about 1 in 7 people have a dental care related fear or anxiety. And that prevalence among middle-aged women, however, may be as high as 1 in 3 individuals. And we know that this has an impact on the oral health of women because women relative to men have much more untreated decay occurring in their mouths. And you get this vicious cycle of dental care related fear and anxiety that makes you avoid the dentist. Also, we know that women have been historically excluded from research, right? They're underrepresented in research. And when they have been included in national surveillance initiatives, oftentimes the numbers at the intersections are not enough to have meaningful investigations. So I looked at NHANES for dental data. I wanted to look among Black women, and there were less than 500 Black women in the NHANES population. And that wasn't enough to do the things that I wanted to do and what I wanted to investigate. And this really speaks to the importance of female-based cohorts. So thankfully, I came from Boston a year ago where I spent 20 years working, and out of Boston University is the Black Women's Health Study. This is a national cohort of nearly 60,000 women. They've been followed since 1998 through biennial questionnaires. I love the way they recruited women. So they recruited women by getting subscription lists to Essence magazine, and then they enrolled their friends and family and got this really robust, very committed cohort of Black women throughout the US. And in 2005, I started working with them to introduce some brief oral health measures. And then in 2016, we said, you know what, we need something way more in detail. So we're going to drill down on the nearly 1,000 subjects that live in Massachusetts, and we're going to do a really detailed oral health questionnaire. And then we're going to bring them into the clinic and look at them clinically, validate all the self-report measures, et cetera. So one of the things that we looked at, so this being a cohort of Black women, repeated measures of everyday and lifetime experiences with racism. And one of the things we measured was this big battery of dental care related fear and anxiety. And we wanted to look at whether experiences with racism, thinking about the population, the dental care workforce, and the known patterns of utilization, we wanted to look at the relationship between racism and dental care related fear and anxiety among this cohort. And those who had had lifetime experiences with racism had a 72% increase in the odds of high dental anxiety. And high dental anxiety in this cohort was twice that of the prevalence found among white women. And what was really interesting is that when you looked at the fear-inducing stimuli for that dental care-related fear and anxiety, across the board, we didn't see anything unusual. Cost, people are worried about cost because why? Insurance models don't cover restorative dentistry at a 100% cost. Many of you have probably paid $500 out of pocket for a crown, and that's a cheap crown, right? So cost causes a lot of anxiety, particularly among caregivers, right? Caregivers of young children, cost is a big deal. None of us like needles or injection. We don't like to be in pain or discomfort. So that's very typical. But if you look at those that had high relative to low dental anxiety, you see a difference in terms of what was most important. So you get pain and discomfort. So recall pain management among women, particularly Black women. You get an unkind or an unsympathetic dentist. There's racial and gender discordance between the patient and the provider. You get a feeling of a lack of control in the dental chair. Right? So it was very revealing to think about, well, how do we tackle oral health disparities when this is the case? We have a lot of work to do. So we also looked at perceived experiences with racism over time. So again, this is a longitudinal cohort. So we looked at declines in self-rated oral health related to experiences with racism. And we found that you get with increases in everyday racism, so in the top quartiles, you get a 50% increase in the incidence of oral health decline. So these have been some interesting studies that have really got us thinking about how do we address women's oral health, particularly among disparities facing populations. All right, women. What does oral health have to do with reproductive health? Well, this diagram shows two different hypothesized mechanisms about how inflammation in the mouth affects the adverse pregnancy outcomes. One is that the bacteria gets into the bloodstream and travels to the reproductive organs and can cause premature intrauterine restriction. And one is that you have distant low-grade inflammation in the mouth that causes inflammation-related issues in pregnancy. However, sorry, you can get it from me later. However, why did we start thinking about this? So in 1996, there was a study by Offenbacher who showed that in a small sample of women, those who had periodontitis, inflammation of the gums during pregnancy, had as much of an 80% increased risk of preterm or low birth weight outcomes. And it was highest among Black women. So then that was so alarming that it was followed up by several studies to the point that the Journal of Women's Health was like, come on, can we move on? Right? Like there's, what are we finding here? Because there had been clinical trial after clinical trial, a Cochrane review, and treatment of periodontitis during pregnancy didn't have an impact. And so what are we doing here? And the thing that the CDC learned as the most informative from all of this work that was done was that it's safe to treat periodontitis during pregnancy. But the real problem here is we don't have cohorts of women to study oral health in relation to reproductive outcomes. The second trimester is too late. By the time they're in their second trimester of pregnancy, we can't do anything about it. In fact, we may be causing harm by disrupting the bacteria in doing treatment in the second trimester of pregnancy. So again, I was very fortunate to be in Boston, where I got to start working with this large North American cohort, a fertility cohort called the Pregnancy Study Online, or PRESTO for short. It's approximately 20,000 women throughout North America, started in 2013. And these are women who are planning a pregnancy. So they identify them pre-conception, and they are able to measure all of the potential informative covariates that might impact fecundability, as well as adverse pregnancy outcomes. And I said, you know what, why don't we just ask about oral health? Oral health wasn't on there. Let's ask about it. So we asked some clinically validated self-report measures for oral health starting in 2019. And pretty quickly in 2021, we were able to publish in Human Reproduction showing that preconception periodontitis resulted in a delayed time to pregnancy. So there were declines in fecundability as a result of periodontitis. We also followed that up with a paper that looked at risk of spontaneous abortion, and also found that miscarriage had a higher incidence among women with preconception periodontitis. And I have current NIH funding right now to continue work with this cohort, where we're looking at gestational diabetes, gestational hypertension, eclampsia, as well as preterm and low birth weight outcomes. And then this observational work will be followed up with a new enrollment of a clinical cohort where we can get women preconception, look at them clinically, and then follow them through pregnancy. Okay, finally, I also spent a lot of my career in the Boston public housing projects. This one was not far from my office, about a quarter mile down the street. And in Boston, the Boston Housing Authority was the largest landlord in Boston. And as you can see from this picture, it's tightly clustered units, ranging in size, but it's a lot of poverty, and it's a very diverse population. Now, about 80% of these households in the housing projects are headed by women. And women who live in public housing, they're twice as likely to be obese and 3 times as likely to have diabetes. So a lot of chronic disease happening in these housing projects. And if you look at their socioeconomic counterparts that are not living in public housing, but they're living in private residences, those in public housing are more likely to be women. They're more likely to be non-US born. They're more likely to be caregivers of minors and less educated. And so I started thinking about, well, what's the social influence aspect happening here? And started to do social network science. And social networks have been sort of hypothesized to be those translating mechanisms of upstream influences to downstream behaviors. And so we have a lot of studies that model social networks in public housing. And what we find is that oral health status and the risk behaviors of these caregivers of women relative to their children, they're socially clustered in ways that could be contributing to these disparities. And oral health status, again, because it's so separated from medicine, it's hard to figure out, how do you navigate it? How do you find care? Well, oral health status may be a central factor in the formation of social networks. And we've also found that Kary's risk behaviors are also socially clustered phenomena, and there's a strong potential here for network interventions. And what's really interesting, when I talk about oral health forming these social networks, what we found is that these women are generating what we call weak ties. And these weak ties are providing them with resources and support. So if you've ever heard of the Granovetter paper, the 1973 Granovetter paper about the strength of weak ties, That's what we're seeing with oral health. Women are associating with others in order to get resources, information, and support relative to their oral health and the care of their children. We've done this in qualitative studies as well, where we've been able to see them talk about the importance of their social networks and being able to navigate oral health conditions. And we have a paper that's about to come out that shows that COVID, one of the things with weak ties is they're vulnerable to disruption. And so we saw a loss among women who had fair or poor oral health, a loss of those weak ties due to COVID. And so we suspect that we'll see further declines in oral health status because they're losing their resources and support, and those have been disrupted. So let's get the gang back together. Let's reunite medicine and dentistry. That is the key mission of the School of Dentistry here at the University of Utah. And we have a number of things that we're trying to do to bring medicine and dentistry back together. That's why I'm here, is because it's a key passion of mine. And if we do that, we can better support women's overall health. Thanks.
How about questions? Questions? And remember, you've got a little button that you can push if you have any questions. Yeah, Nikki.
Thanks for this great talk. So it had me wondering, is there research to support the dental spas that where you get your hand in paraffin wax, maybe you get the...
I'll stop you there, no.
Okay.
Evidence-based dentistry is still a very emerging field.
Well, I have a question about cosmetic dentistry. So is there a difference between men and women in how they access cosmetic dentistry?
I would suspect so. However, there is no way to study it because we don't have any databases. I mean, we'd have to launch a study on that, probably a survey study of some sort to be able to measure that. But dentistry's been very careful to keep itself segregated from medicine. They want all the benefits and none of the burden. And so it's political. There's a lot of reasons that there's been a push to keep dentistry separate. They want their autonomy. They want to be able to do their cosmetic dentistry. They want to be able to charge as much as they want for it. And if you want a history on the dental school, the reason the dental school was started here at the University of Utah was to care for the underserved, to care for those populations that Utah dentists were not caring for. And so that's why in our clinics here, we see more than 40,000 patients per year, and they're all underserved. So we treat Medicaid patients and patients who cannot pay. We have a philanthropic fund that covers a lot of the care. So,
Well,
sorry.
thank you. Oh, Nikki, go.
And how do we get more women in dental school?
Great question. I wish I had a specific answer. We need women in dentistry, and there's been a lot of mechanisms that have gone towards that. I'm lobbying the NIDCR right now based on a workforce working group that I've been involved in, trying to get funding for women for pipelines for women in dentistry. It's actually gotten a whole lot better. In fact, we have a 50-50 split men and women in our dental school here. It's getting a whole lot better. We need more diversity. We need women who come from underrepresented groups in dentistry. And we're working with an NIDCR R25 program to try to get them summer research programs, pipelines to dentistry. We do training programs, et cetera. It's the gender diversity in dentistry has gotten a whole lot better. And then we need to move to trauma-informed care because that doesn't exist in dentistry, right? Okay, sorry. Soapbox.
And is there any effort? Do we have a dental hygiene school here?
We have lots of dental hygiene schools in Utah, not at the University of Utah.
Well, it'd be good to have one because for many people who have dental anxiety, they're afraid of the dentist, but they're not afraid of their hygienist. And getting a hygienist might be the access into underserved people
Yes. So that's another political issue. There's this position called a dental therapist, which is like a bridge between a dental hygienist and a dentist, where a dental therapist can engage in restorative dentistry. It has not been approved in Utah, and there's a big push against dental therapists.
Well, for all of us who really support nurse practitioners and how much they have enhanced the quality of care of women, I'd say if there's any equivalent in dentistry, we should definitely make that push.
Yes.
So I'm sorry, I can't figure out this microphone, but hopefully I'm speaking loud.
Yeah.
I was just wondering if you have published anything that your experience is working with this almost exclusively underserved population of 40,000 people. If you've got any publications.
Repeat the question.
Yeah, so she's asking about the work that the dental school does on these, more than 40,000 patients per year. So I'm actually writing an R01 right now. I'm like this close to getting 10 years worth of Medicaid data so that we can study the effect of oral health policy. Oral health policy is great here in Utah. That's a positive thing. We have comprehensive dental benefits for Medicaid populations. It's been approved it was approved in the 2023 legislative section. We're taking over all adults in Medicaid. We currently have blind and disabled, elderly, and targeted adult Medicaid with substance use disorder. So now's the time to start doing the research to show the impact of that increase in access on these populations. I'm also working with our dental databases. I have a meeting with Reed Barney almost every 2 weeks, who's the director of the Enterprise Data Warehouse, so that we can develop a clinical database with which we can study the oral health needs of these populations. So yeah, it's all coming down the pipeline. Yeah.
Thank you. Thank you very much.
I'm going to introduce all three of our next speakers together because they're going to form a panel on environmental, with the focus on mental health in the environment. And certainly we've been understanding that the environmental issues, whether it's altitude or air quality, affects our heart and our ovaries and our pregnancies, but we're going to be talking more about our mental health. So to start with, I'd like to introduce Emily DiBlasi. And Dr. DiBlasi is an early career researcher at the Department of Psychiatry and the Huntsman Mental Health Institute. Her research focuses on the genetic and environmental factors that contribute to complex neuropsychiatric human traits such as substance abuse disorders and suicidal behavior. She uses demographic, genealogical, and clinical and genetic data to identify risk factors about suicide and overdose deaths, and she's building a research program that will specifically focus on women's specific risk factors and outcomes. We're going to have each of our panel members are going to have a quick discussion on their own, and then we're going to open it up to questions. So would you like to start?
Thank you. So I'm going to be talking about suicide, and this is, of course, a difficult topic. So if you feel like you need to leave the room or step away, please feel free to do so. And here I'm just putting up a few effective resources, which will be available. So there is really no single cause of suicide. Suicide does not equal depression. And that's really one thing I'm going to drive home today in the next 5 minutes. So 1 in 4 people who die by suicide is a woman. And these women who die are really understudied because most people who die are men. So recent rates of suicide have really increased, especially for women, increased 44% since 1999. And currently in Utah, more women die of drug overdose than men, which is just happened in recent years. And so suicide is currently the 4th leading cause of mortality for women. So Utah actually has really unique resources for studying suicide. We currently have a really high suicide rate, and you can see in this map here, the dark blue are areas where suicide rates are really high, and most of the Intermountain West, the suicide rate is very high. We roughly have about 650 suicide deaths per year. 23% of those deaths are women, and about 60% of those women have experienced a perinatal period. So many of them were mothers. Because of a 25-year collaboration with the Office of the Medical Examiner, we currently have the largest population-based data resource and biobank on suicide death. And I'm just gonna give you a brief overview of the Utah Suicide Mortality Risk Study. So that's that big data resource and population resource. So we currently have comprehensive data that is de-identified on Utahns that died by suicide from 1999 to present day. And by comprehensive data, I mean identify any of the individuals. So we link all our records through the UPDB, and de-identified data is given to our research team. So one concept I'm just going to talk about today is the exposome. And so you can kind of think about the exposome kind of like you would think about a genome. So this is all the environmental exposures that an individual experiences throughout their lifetime. And in our research group, we really think about how to understand these diverse exposures and how they interact with genetic factors to really influence preventable death outcomes. And so I'm just gonna kind of go over the concepts we think about, particularly in the research group in relation to the exposome. And these are physical factors or environmental exposures. So Amanda Bacon is doing some really great work looking at how temperature and air pollution increase suicide risk. And another thing we're focusing on particularly are allergies. And then some of the other things we might think about when it comes to suicide death. And these are things like socioeconomic status, socio determinants of health, things like healthcare access and insurance. So everything here in bold is what we can look at with our data and when we are looking at with our data, but there's of course other considerations. We want to think about lifestyle, sleep, employment, substance use, diet, exercise, as well as psychiatric conditions, as well as trauma. And so in our group, we're really focusing on sexual trauma, child abuse, familial suicide risk, as well as pregnancy-related factors, which I'm really focusing on. And so when we think about the exposome, we think about how these exposures really interact with biological responses, and how do those biological responses then ultimately end up in chronic diseases. And so the last little bit, I've really been focusing on comorbidities within women that have died by suicide. And so I'm just going to really briefly highlight two of the studies that I have done. So I did a series of what's called phenotype-based phenome-wide association studies. And that is where I, in a really broad way, look at all the diagnostic characteristics of women who died by suicide and Utah controls. So I looked at over 1,700 Utah women that died by suicide and over 11,000 population-based controls. And I did two series of studies. One was where I compared 128 female-specific chronic conditions to the controls, and the other study is comparing over 1,500 general common chronic conditions that are not specific to women, but both men and women. And what I found was really there are female-specific risk factors that we should be considering when we look at suicide risk. And so some of the top findings are things like inflammatory pelvic diseases, cervical cancer, mental disorders during and after pregnancy, as well as endometriosis and dysmenorrhea are really elevated in our women's suicides compared to controls. And so there are lots of other things we can be looking at. However, what I did here was kind of like a really broad diagnostic comparison using ICD codes. And so there's a lot of chronic female conditions that are left out here. So a lot of my work is really focusing on defining this using the electronic health record and really looking at these characteristics more to see what else might be involved. And so with the other study looking at all the conditions, kind of here is the big picture we see in comorbidities in women that died by suicide. So all these conditions listed here are really elevated in female suicide deaths in Utah. And so I just talked about some of the female-specific chronic conditions, but there's lots of other things that you might see and like say, okay, that makes sense, maybe due to stress and trauma, but we rarely look at the big picture. And here's kind of looking at the holistic picture. What are the diagnostic profiles in these women? And so we see things like chronic pain, back pain, incontinence, IBS, Of course, all the psychiatric conditions, lots of previous suicide attempts and overdoses, migraines, lots of headache syndromes, epilepsy, things like multiple sclerosis, sciatica, vertigo, lots of inflammation and fibromyalgia, as well as chronic effects of substance use disorders and alcohol use disorders, as well as heart disease and hypertension. So with that, we just want to look at kind of a more holistic view of these exposures and how that results in chronic conditions. And we're seeing a significant amount of multimorbidity. And this is important because 90% of people who die by suicide have had contact with a healthcare provider in the last year of their life. So we think there are a lot of opportunities for prevention. And with that, I just want to highlight some of the people that I work with in the study.
I'm going to ask you to hold your questions. We'll have a panel discussion on these. And we're next going to hear from Dr. Shami Kanekar, who is a research assistant professor in psychiatry at the University of Utah School of Medicine and the Huntsman Mental Health Institute. And since 2012, Dr. Kanekar collaborated with Dr. Perry Renshaw to develop a novel sex-based translational model, animal model, to study the neurobiology of major depressive disorder and suicide at altitude. I hope she's going to get into that a little bit because it's a phenomenal finding. And her group is the first to show a detrimental impact of living at moderate altitude on mental health disorders. If you go back to that map where suicide occurs in the US. Dr. Kanekar, would you like to have 5 minutes and then we'll.
So I only included 2 slides because I thought that's what we were supposed to do, given the limited time. But I'm going to switch gears here and talk about animal studies based on demographic data that shows that. See, how do you do the? Oops. And how did I use that? Okay, got it. So these are some figures from demographic studies. The first over there, there it is. The first couple of studies looking at suicide rates across the US versus altitude were published in 2010, and one by Perry Renshaw in Perry Renshaw's group in psychiatry. And this is a really dramatic image of suicide rates across the US in relation to altitude across the US. And you can see the darker areas, the dark brown, are the highest altitude regions in the US. And that's exactly where the highest rates of suicide are noted. Studies found that, I'm sorry, I keep losing this, there it is. Rates of suicides increased from about 2,000 feet above sea level. And since that time, this pattern has been found to exist across the world. Now it's 9 different countries, which shows that suicide rates increase with altitude of residence, despite different sociocultural and economic risk factors. In addition, studies in 3 different countries showed that rates of major depression also increased with altitude. And as Emily mentioned, Utah is particularly at high risk for suicide. It's on and off has been noted as the state with the highest rates of suicide. And this is despite also having the highest rates of antidepressant use. And then men have higher rates of suicide versus women, but as Emily also mentioned, women's suicide rates are increasing by 50%, or have risen by 50% in the last decade, while men's suicides have risen by much lower numbers. Okay, there we go. So this is a really busy figure, but we established the animal model to study whether housing at moderate altitude might impact biomarkers of MDD and also suicide. So living at altitude is linked to chronic exposure to hypobaric hypoxia. So with the low pressure at altitude, the number of oxygen molecules in a certain volume is lower than it would be at sea level. So when you breathe in a lung full of air, you essentially get less oxygen in each breath than you do at sea level. So what we did was we housed rats, Sprague Dawley rats, at 3 different altitudes, sea level, and in all these graphs, sea level is the black bar, and altitude is either 4,500 feet, the red bar, or the blue bar is 10,000 feet. So when rats are housed at these 3 altitudes versus sea level, rats of both sexes exhibit elevated depressive symptoms in the forced swim test. Rats of both sexes exhibit anxiety symptoms in a battery of tests. And we also see biomarkers linked to both depression and anxiety. And shown here is rats exhibit elevated serum IL-6 or interleukin-6, which is a marker for postmortem for suicide deaths versus deaths by other causes. On top of these deficits that are seen in both sexes, females also show anhedonia in the sucrose preference test. That is, they take less pleasure from the pleasurable stimulus of eating sugar when they're housed at altitude versus at sea level. Females also show panic-like symptoms in anxiety tests. And the big one over here is when rats at the 3 different altitudes are tested for methamphetamine preference. Females respond, show much higher preference for methamphetamine after housing at altitude, while males really do not change. And this is just when we provided them with 2 different doses of methamphetamine, and that the pattern does not change. So since another biomarker of MDD that rats at altitude exhibit is lower brain serotonin. And so we looked at efficacy of SSRIs, that is selective serotonin reuptake inhibitors, which form about 80% of prescribed antidepressants across the US. And SSRIs require a certain amount of serotonin to function. And we figured since serotonin levels are lower at altitude, we figured that these may not work as well. So when we housed rats at sea level, this is the black bar is controls, and then the first 4 are SSRIs, and this is our positive control, the blue bar, which is a tricyclic antidepressant, disipramine. So when we looked at animals housed at sea level, both sexes responded to all 4 SSRIs, as well as to the tricyclic antidepressant, disipramine. However, after housing at each of 2 moderate altitudes, 3 of 4 SSRIs failed to respond failed to show antidepressant-like effects. And note here that antidepressant effects are a lowering of immobility in the first swim test. So fluoxetine, the yellow bar, or Prozac, paroxetine or Paxil, the green bar, and escitalopram or Lexapro, the red bar. All three of these did not work in rats at altitude. However, sertraline, the turquoise bar, or Zoloft, continued to work in animals at altitude. And we think this is because sertraline is not only a serotonin reuptake inhibitor, but it also inhibits dopamine reuptake. And so we think its activity here is based on reuptake of dopamine. So this implies that since SSRIs form over 80% of prescribed antidepressants, if SSRIs do not work as well at altitude, it implies that treatment-resistant depression is higher at altitude. And we know that treatment-resistant depression is highly linked to suicide. So all of these factors that I'm showing you here are, as Emily mentioned, deficits that are linked, that are risk factors for suicide: depression, anhedonia, anxiety, cognitive dysfunction, and substance use disorder, as well as treatment-resistant depression. So I want to end with showing some demographic studies on substance use disorder with altitude. A study from about 2014 had shown that both methamphetamine misuse and cocaine misuse increase with altitude of residence. And more recently, we did a study looking at prescription opioid misuse and found that if you look at the whole population across the US, there's no relation seen to altitude of residence, and there's no relation seen in men. But if you look at women alone, there is a positive correlation between altitude of residence and elevated substance use. And this was, we also found that fatal overdose by prescription opioids increased with altitude in both sexes. And we think that's because opioids dampen breathing, and that in combination with hypoxia ends up being a toxic combination. So these data together indicate that there's a biological risk for suicide that might occur with chronic hypoxia exposure at altitude. And it's important to note that this pattern is not just seen in people living at altitude. Higher rates of suicide and major depression are also seen in people with chronic hypoxic disorders, such as COPD, asthma, cardiovascular diseases, versus healthy people, and also versus people with chronic diseases that are not linked to hypoxia. So basically, chronic hypoxia forms a biological risk for MDD and suicide. Thank you.
That's an enormous amount of research, animal research. So everybody take a deep breath. Everybody take a deep breath. And I'm going to go introduce Anne Kirchhoff, who is a tenured associate professor in pediatrics at the University of Utah School of Medicine and the Huntsman Cancer Institute. And she's a healthcare services researcher. In other words, she looks at the primary concerns evaluating patient outcomes related to healthcare access and cancer's-related effects. So thank you.
Great. All right. Thanks so much for having me. I'm going to keep this quick. So before I get started, I just wanted to acknowledge my research team because we wouldn't be able to do all of this work without their wonderful help. So if you want to learn more about what we do, our website's down there at the bottom. But basically, I just have this one slide to talk about my team's work around climate change and cancer outcomes. And so we became really interested in this area, and it was really sparked by one of my former team members, Judy O, who is an environmental epidemiologist. And we had been doing studies that looked at how cancer treatment can cause unfortunately, pretty severe health problems in cancer survivors. And cardio and pulmonary health problems are very common. So you think about that, someone going through cancer treatment, having cardiovascular and pulmonary problems. Well, think about air pollution. Air pollution affects all systems of the body, but unfortunately, respiratory and cardiovascular problems are common. And so if you think about Utah, right, in the winter, we get inversions where we get high levels of particulate matter. During the summer, high levels of ozone, right? So all of these things are bad for the general population. But what does this mean for someone who's going through cancer treatment and maybe is already at a high risk for developing these health problems? So our team utilizes the Utah Population Database to be able to look at questions around how air pollution and other environmental factors affects the health outcomes of cancer survivors. So I'll just walk us across some of our results and then talk a little bit about our next steps. So we have two questions that we've been exploring. One is, do cancer survivors respond to air pollution differently than the general public? And what survivors are at higher risk? And one of the novel things we can do here in Utah using the Utah Population Database is actually use people with a cancer history and compare them to people without a cancer history, because we can get information on them kind of throughout their lifetime. And so a lot of the studies that have been done around air pollution and cancer outcomes have really just been limited to cancer populations. So this is a big sort of innovation that we're able to do here. The other question we're interested in is, does air pollution have more severe effects on survivors who have had certain treatments? So we know certain chemotherapies, for example, like anthracyclines, can cause cardiovascular health problems. Not everyone gets these types of treatments, so are we able to dig into this a little bit more? So I'll just walk us down the middle. So we've been able to leverage the Utah Population Database for several studies. Originally, we focused more on pediatric, adolescent, and young adult cancer survivors. So that's kind of the results I have here in the middle. So I just want to highlight two publications we've done so far. One, we were able to look at survivors of childhood cancer and compare them to a population without cancer from Utah. And we found that those who had received chemotherapy were much more likely to be hospitalized for respiratory-related health conditions compared to the individuals without cancer. We were also able to do some studies where we looked at not just pediatric, but adolescent and young adult survivors, and found that those that were exposed to higher levels of air pollution, so with these studies, we've been looking at PM 2.5, are more likely to have higher mortality, right? And so this is really worrisome. So we were able to look at sort of air pollution exposure over several years after diagnosis, so kind of chronic exposure, and this is associated with higher mortality. Another question we're interested in around who might be at higher risk is around socioeconomic factors. So if you look down here, this is from that same paper where we looked at mortality as our outcome, and we saw as increasing levels of PM 2.5 happened, that individuals who lived in lower socioeconomic status neighborhoods in Utah were at higher risk of mortality. So this all brings up some questions of thinking about how to dig into this a little bit more to really understand these risks. With these studies in the middle here, we were able to do some analyses to look at specific cancer groups. And one group that came out as having higher mortality were young women with breast cancer. And so with that in mind, we've now actually been able to spin this into some additional studies where we're trying to do a better job of getting more granular information on cancer treatment and other sort of factors that might play into that risk, such as socioeconomic status. So over here on the far right, our next steps are that we got a R01 recently to really dig into breast cancer more. We've been sort of limited in our ability to look at things like treatment using cancer registry data. And so with this new grant, we'll be able to pull in records from the University of Utah and Intermountain to hopefully get a better feel for the types of treatments patients are getting. But what we're really interested in doing with this grant is not only looking at chronic exposure prior to diagnosis, but do a better job of looking at sort of the exposure that patients are getting during treatment to understand their health outcomes. The other aspect we're adding to the study is to really understand more how climate change is affecting. So we're looking at air pollution in our earlier studies, but that's not the only thing that's going on, right? Wildfire smoke is becoming more common. Unfortunately, things such as extreme heat are more common, and there's studies in the general population showing that the synergistic effect of all of these together really increases mortality. And so this is what we'll be looking at in this new grant. Would love to hear if anyone's interested in collaborating. We'd like to move into other disease groups, and we're starting to think about interventions as well too. And so I think a lot of what has been talked about today in the session around, women and their sort of connection to the health system has really started us thinking about sort of the intersection of some of these factors we're seeing and sort of ideas that we might have for intervention work. So ideas that we're sort of playing around with are, women tend to be sort of the main medical decision makers in homes. We've done some qualitative work showing that there's sort of a low level of knowledge of air pollution and sort of the impact on cancer survivors. They tend to be sort of making those decisions. So could we work with them, for example, for a home where there's someone with a cancer history or going through a cancer treatment, to do things such as getting HEPA filters in the home or encouraging the family to invest in wearing masks, those types of things. So lots to come, and was really glad to get invited to be able to talk about it. So thanks.
There's a red button on the bottom. There's a red button on the bottom. I don't think this is working yet. Oh, yes, it is. Okay. Well, I have one quick question. That's for you. We know that women in the home are more likely to be the cookers, people spend more time in front of the stove. And so around the world, women's risk for lung cancer has to do with their exposure in cooking. And we know that people, and I have polluted my own household with trying to make croutons on a stove. So what are we doing to help women who have cancer to try to keep their indoor air pollution?
Yeah. I mean, I will say this is a very sort of early days in our work. I think one thing we'd like to do with some of these bigger population level data analyses is to start pairing it with more primary data collection to really understand these types of health behaviors, so that when we're starting to think about interventions, we can really design them with sort of the range of behaviors and sort of considerations we need to have. So I mean, I think it's a really interesting time, right? Like there's been a lot in the news and sort of politically around gas stoves and things like that. So I think it's actually a really sort of good time that people might be receptive to this type of intervention.
So how about questions? We have three experts from different domains talking about survivability related to environmental issues. Certainly, we have a whole lot of important work that's being done here in Utah on altitude, on suicide and overdoses in women, and of course in cancer survivors. Any questions? Yeah.
Can you hear me? Is that
a little louder?
All right, well, hopefully this little microphone works. My question is, based on the altitude and the effects that it may have on depression and suicide, is that taken into consideration? You can acclimate or acclimatize.
Because I'm looking on the CDC website, like about how we acclimate to higher elevations and altitude. We talked about these here. And for those individuals born here in Utah, are they committing suicide shortly after living here? Is that the relationship, or is most of the human body adapt?
Right, but okay, let's quickly repeat the question, and that is the rate of suicide in newcomers or old comers? Can I briefly get it down to the people who've acclimatized?
The demographic study doesn't really analyze that. Can you hear me with this?
Yeah.
But there's evidence from Dr. John West from UCSD, who's done altitude studies for his whole career. And he found that even though we do adapt, we don't fully adapt for the hypoxia at altitude, even as low as what we experience in Salt Lake City, which is pretty moderate. So the human brain doesn't adapt. Breathing wise, we breathe harder at altitude, but that doesn't take care of the oxygen deficit. And this is shown in clinical studies looking at healthy people in Salt Lake City versus either LA or the East Coast at sea level, where they show that residents in Salt Lake City have lower arterial blood oxygen levels than people in LA. And then when you look at brain energetics, people in Salt Lake have lower brain creatine levels, which is a bioenergetic molecule in their forebrain, versus people on the East Coast at sea level. So these of course don't account for have you just moved here, but it does take into account people that have not traveled out of that altitude for a year. But adaptation, it doesn't happen fully.
Okay, thank you. And a question in the far back?
Would it be worth to try and further elucidate that by taking those patients in San Diego or LA and using an altitude tent where like the athletes that are using like hypoxic conditions at sea level that control for other variables?
Yep.
Can you repeat the question?
Yes. He asked whether you could take care of that by taking people at sea level into hypoxia chambers or hypoxia tents, like is done for athletes. Now, studies like that have been done with extremes of hypoxia. So there's a study that showed that cognitive function in healthy adults is severely reduced from prior to hypoxia exposure to after, and I think it was like 10% oxygen, which is what you would experience at Mount Everest, right? Versus here. But you do see cognitive deficits after maybe an hour of treatment, something like that. So they have shown that hypoxia in the acute phase at least can affect you. Now, it's not that I haven't seen any long-term experiments done like that. Thanks.
There's a question, yeah. You may have to just stand.
So Emily, I really enjoyed your presentation and nice to meet you in person because I know we've conversed via Zoom, but I've done a lot of work in endometriosis and the debilitating pain associated with endometriosis. And I'm wondering if in the Utah population database to get at procedures and prescriptions, because one of the big, so if you excise or ablate the lesions, and this is actually, there was a documentary that was just done on kind of endometriosis and endometriosis pain. Have you thought or have you yet brought in therapeutic procedures or medications to see how that might mitigate the risk of suicide, which I think would be very informative?
Yeah, that's definitely our next step. So we do have access to all that data and we have that in hand. It's just looking at all that. It's a great idea. Yeah.
Okay, one more question. Dr. Barnard?
This is for Dr. DiBlasi. As I was looking at all those different medical or gynecologic issues and psychiatric issues, it seemed like the elephant in the corner was domestic violence and abuse. And do you have data to track that? It seems like that might be.
Yeah, so a lot of the data we have is more interactions with the medical record. And so we have a limited amount of data on the life circumstances of these individuals. And I agree that, that might be the precipitating event that causes all these things. But I think the way we look at it is just more like, maybe it doesn't matter what the initial cause is. Like, let's just try to look at some actionable targets, something that we can do. But I mean, that's a really important piece of the picture. We don't have that in our data as fully.
I think we're going to get started in the interest of time here so we don't get too far behind. And I want to thank all of our online participants. Thank you for being with us. And we're monitoring the chat, and you can put your questions in there and we'll be happy to answer them. One of the crosshairs in women's health and all human health is medications. And many of us have to be on medications for various reasons. And we thought it would be really important, and we had people actually ask us to have a discussion on this, on what happens with medications in women as opposed to men, and how can we use these pharmacogenomic tests that are being done on our patients to understand their medication sensitivities and address drug outcomes in women's health. And so, of course, we asked the best in the world, which is a panel here from the University of Utah, Dr. Diana Brixner, who's professor in the Department of Pharmacotherapy and is the founder of the Pharmacotherapy Outcomes Research Center, or PORC, here at the University of Utah. This is a big deal. She's also the past president of both the Academy of Managed Care Pharmacy and the International Society of Pharmacoeconomics and Outcomes Research. And joining her is Dr. Joseph Rauer, who's a board-certified clinical pharmacologist, and he's a research assistant professor in the Department of Pharmacology and Toxicology, and is a co-director of the Center of Human Toxicology. And he really is focused in on personalized medicine tools, especially also in pediatric dosing. And also Dr. Ryan Nelson, who is the medical director of precision medicine, an adjunct professor here at the University of Utah, and he really applies precision medicine in pharmacology. So I want to thank you all three for being here, and I'm going to turn this over to Dr. Brixner. This is the slide advance right there.
All right. Thank you so much, Kathleen. It really is a pleasure to be here and talking with all of you. I solicited 2 men, so we increased the percentage of men that are actually at the program this afternoon. So thank you both for coming and speaking with us today. To start our session, I wanted to ask 2 questions to kind of ground us as to how much are we actually exposed today, everyday, daily practice, to pharmacogenomics and treating our patients. So 2 questions. One is, how many in the audience have actually requested a patient to go and get a pharmacogenetic profile for themselves, for their patient? 2. This is great. Of course, you 2 don't count. Yeah. Okay. So a few. Okay, a few. Let me ask part 2. How many of you have had a patient come in with a report in hand of their test results and asking how that would impact treatment? Interesting. So it's about the same, right? So I'm going to say the majority of the rest of you, not so sure whether you should request it or not for your patient, and you're not seeing your patients actually come in with the results. My prediction is over the next 5 to 10 years, the number of you that would raise your hands when I ask those 2 questions are going to increase exponentially. And so we're excited today to give you a little window of the world and around why and how that may happen. So we only have 25 minutes, so we're going to go through kind of quickly our 3 main agenda items. The first is, what is pharmacogenetic testing and why should you care? Why does it really matter? A few comments, introductory comments for myself. I'm then going to hand it over to Dr. Rauer to talk about how the results of these tests can impact drug outcomes. Again, to give you some real world examples to show you biologically how this works and how this happens. And then we're going to have Dr. Ryan Nelson close us out on understanding a little bit what's very important is operationally. How exactly are these tests ordered? Even more intimidating is that when these results come back at you, how are you supposed to interpret them? What do they mean? And then how do you actually put them to use in the decisions you make on how you're going to treat your patients going forward? And in the hopeful time that we have left, we're going to have a few questions to ask these 2 as well as the audience to provide any input and feedback. So, very brief in a nutshell, what is pharmacogenomics? It's really a combination of 2 sciences. One, pharmacology, the science of how drugs work in the body, as well as genomics, the science of how genes work in the body, hence the name pharmacogenomics. If we look at precision medicine, what does it really mean? Well, precision medicine is trying to get more precise about the drugs you're prescribing for your patient in treatment, and you're doing that by biomarker-guided therapy. So in other words, by understanding the DNA, the RNA profile, protein profiles of your patients, you can improve the therapeutic process. You highly increase the likelihood that your patient is going to react appropriately to a certain treatment choice. Pharmacogenetics, pharmacogenomics, 2 terms that I don't always get the definitions of each straight. So for you all, the pharmacogenetics means you're talking specifically about a gene and a drug pair, more precise. Whereas pharmacogenomics is broader, it's looking at multiple genes combined that influence pharmacotherapy choices. Now, why is it important? What does it matter? Well, there's two components here on this slide. Kind of my entire career of research is looking at value in pharmaceuticals. How can you increase the quality and outcomes for patients and do this while reducing overall costs for the patient and health systems? Well, pharmacogenomics impacts both sides of the equation. As far as reducing cost, if you get a more accurate treatment that works more quickly and appropriately for a patient, ultimately you're going to reduce total patient care costs. You prevent adverse events, and you'll hear from our other two panelists exactly how that happens when you apply pharmacogenomics to therapeutic decisions. You avoid pharmacotherapy visits that aren't necessary because, again, you have more precise treatment choices. And you may mitigate CMS performance penalties by, again, getting the right drug to the right patient at the right time using pharmacogenomics. Now, on the other side of the equation, it also increases quality. You can expedite time to treatment success, beneficial to you, beneficial to patients, increase patient safety and satisfaction, optimize provider patient time use, and also improve clinical efficiency and efficacy. All positive outcomes. So, in conclusion of my introductory comments, what are some actual clinical applications? Well, related specifically to women and breast cancer, it's one of the most common disease areas where genetic testing is actually used to tailor chemotherapy regimens based on individual responses. A very famous example is a test called Oncotype, which will predict how a woman will react to therapy to prevent reoccurrence of their cancer. So in other words, if you see a genetic test saying that you will respond and this does decrease your risk, you know you're making a good decision for your patient. If the results show that this patient is actually not going to respond to the treatment, you're sparing that woman from being exposed to unnecessary chemotherapy of which she's going to get no benefit, but yet will still suffer all the adverse events associated with that chemotherapy. Hormone replacement therapy. Genetic variants for each of the women that you would treat are influenced by hormone metabolism. So therefore, testing, understanding genetic profiles can really provide guidance into appropriate hormone therapy choices. And then a broader application to certainly both men and women, but many women are exposed to cardiovascular medications. There are a lot of genetic variants that affect drug metabolism of many cardiovascular medications, and that therefore a personalized design can improve outcomes and reduce adverse events and costs. So that's my brief introductory comments. With that, I'm now going to hand it over to Dr. Rauer to go into some of the results and impact on outcomes.
Thank you, Dr. Brixner. Okay, so I definitely come more from the pharmacogenetic side of things. I take kind of a targeted drug gene kind of investigative approach. So I'm going to talk mostly from that perspective. So, and distill, you know, a semester of graduate school down into one slide. So I apologize if it's a little dense. What is a single nucleotide polymorphism, or a SNP? It's a change in a nucleotide base pair within your gene, okay? And what we all know about genes encode amino acids build proteins. And so if you change a gene, you might change an amino acid, which might mean that you change the expression or function of a protein in the body, okay? The way we determine if an individual has a SNP of interest is we take a sample, be that blood or saliva or buccal swab. We take and we isolate and purify the DNA in that sample, and then we amplify it in solution with probes that either have the wild type gene or the variant gene of interest, and then we tag those probes with fluorescence, okay? And essentially what happens in a quantitative polymerase chain reaction, or qPCR instrument, is it will amplify your DNA, add one of those two probes depending on what DNA is present, put fluorescent tags on there, and then you can actually quantify whether an individual is a homozygous wild type individual, which you can kind of see in, if I can get the laser pointer here, you'll see like a cluster here that's homozygous wild type, heterozygous, So meaning they have both the wild type or the kind of common or ancestral allele, and a variant, or they might be homozygous variant. And what that tells you is a little bit about drug disposition. So what the drug does once it goes into your body, how it gets absorbed, how it gets distributed, metabolized, and eventually excreted from the body. Okay? One thing we know is that there are a lot of proteins in the body. I don't think that comes as a surprise to anybody. But about, oops, let's not hit the forward button, let's hit the laser button. There are about 75% of drugs that are commonly prescribed are metabolized, okay? Most of those, about 50% of them, are metabolized by a protein called cytochrome P450, or one of its isoforms, okay? So that's a large number of drugs that go through this one enzyme, this enzyme that we know to be highly polymorphic. And so if there are changes in the genes that encode that enzyme, there's likely to be changes in the expression or function of that enzyme. And as a result, you might get a change in either drug concentrations you see in the body, or eventually the effect of the drug on the disease you're trying to treat. Importantly, in the sense of this symposium where we're looking at women's health, you can also have polymorphisms within drug transporters that help get drug from your stomach, say after you take it orally, into the body, into the bloodstream, and into certain tissues of interest. One that might be particularly interesting here, so we have drug transporters called P-glycoproteins, which actually prevent drugs or certain xenobiotics from getting into places. They're efflux transporters. They kick drug back out of tissue. They're highly prevalent in the placenta, and also known to be polymorphic. So there's a risk, depending on what polymorphism you have, that you may actually, if you're taking a certain drug, predispose the placenta and fetus into potentially having higher exposure to a drug that would otherwise have been effluxed by PGP. So some classic examples of kind of SNP gene drug pairs that we like to think about here. The most common one that I think about is this metabolism of codeine into its active form, morphine. Okay, that's mediated by cytochrome P450 2D6. Again, known to be polymorphic. For some individuals, the polymorphism that they carry says that they are a poor metabolizer of drugs through the CYP2D6 route. Okay, so if you're relying on codeine being transformed into morphine through CYP2D6, and the person can't do that, they're not going to get any analgesic benefit from codeine therapy. On the flip side, you could have a SNP that says you're an ultra-rapid metabolizer, in which case they break codeine down very rapidly to morphine. You actually get to a point where you have too much analgesia, potentially an altered state, and in extreme examples, you get to potentially respiratory distress. So you go from no efficacy to too much efficacy and toxicity. So that's why it's kind of an important concept to think about, depending on the drugs you're prescribing and depending on the genes that might interact with that drug. When we think about this in women's health, two kind of key ideas or key examples popped in my mind. One being estrogen metabolism. That is mainly done by cytochrome P450s, which, as I've already mentioned, is highly polymorphic. And so depending on what polymorphisms you have, you might have different metabolic profiles of estrogen, which obviously can impact a lot of things. And then Dr. Brixner mentioned kind of the breast cancer side of things. So one of the compounds we use to treat breast cancer, tamoxifen, actually has to be activated, kind of like our codeine to morphine story, has to be activated by cytochrome P450 2D6. And so you have the same sort of idea where some people who can't activate tamoxifen into its active form don't get any benefit from the drug, whereas some people may require a dose reduction to avoid any unwanted toxicity from the drug. And so to kind of transition this more towards Dr. Nelson's expertise, kind of a brief talk about how this actually gets implemented in the clinic. Several companies now actually have genetic tests where they will go through, they'll take a sample, and they will provide a report, as some of you have mentioned that you might have seen in your clinic, that walks through all the known kind of drug gene pairs and provides advice based off an individual's genotype for that gene of interest. The unfortunate truth of this, though, is that in order for this to get covered by insurance, to actually get utilized by the clinician, we have to have a lot of knowledge and a lot of evidence to prove that that drug gene pair should be implemented clinically. And unfortunately, our knowledge about the importance of this and our knowledge and evidence supporting specific drug gene pairs aren't always concordant. And so there's, definitely a little bit of lag in the evidence compared to what we think we can do within this field. There are definitely success stories. So if you go to, PubMed and search for CPIC guidelines, Clinical Pharmacogenomics Implementation Consortium, CPIC, you can find, it doesn't roll off the tongue very well, sorry. But you can definitely find guidance for some drugs in the literature that say, kind of like the table that I've shown here for tamoxifen, here's what to do based on a genotype, here's how to dose this individual based on a genotype. A story from my own research, so we found for tacrolimus, which is an immunosuppressant used following pediatric heart transplant, that people who express the main enzyme that breaks down tacrolimus, these children actually required a 2.7-fold higher dose than children who don't have that enzyme, who don't express that enzyme based on their SNP. And that's pretty significant when you're talking about a drug that has a very narrow therapeutic index, or difference between an effective concentration and a toxic concentration. And so fortunately, based on this research, we were actually able to convince the pediatric heart transplant team to start genotyping these kids before transplant to improve dosing immediately after transplant and hopefully get them to the right dose a little bit quicker, treat them better. And so with that, I'll transfer over to Dr. Nelson.
So before I talk a little bit about implementation and some of the outcomes, the first thing that I really want to use as a use case argument here is 4 data points from a study that was done by the Kentucky Teachers Retirement System, where they took a little over 5,000 patients in the observation arm compared to a control arm that was about 4-fold higher. And they had a clinic where medication therapy management by pharmacists looks at the overall profile of medications that a patient is taking, and then tries to tailor those medications to not have drug-drug interactions, or in some cases, drug-gene interactions. When they did this study, they had one arm that did genotyping and one arm that did not. The 5,000 were the ones that had genotyping done. And by considering their genotype and trying to alter pharmacotherapy accordingly, they found a 6.8% reduction in emergency department visits, a 15% reduction in inpatient encounters with these individuals within the cohorts, and a $218 per member per month savings. That led up to $37 million of savings over 32 months. This is not insignificant money. And behind that money are actual untoward effects that we oftentimes are blind to their actual correlates or contributions from genotype versus gene-drug interaction compared to drug-drug interaction, or if it's a lifestyle or adherence thing. The thing that I think is important to note about this is not just pharmacogenetics that is going to be the only thing that matters in what you're doing with your pharmacotherapy decisions, but it is one of many tools that clinicians at large need to collaborate in order to integrate into decision-making. Now, there are a few hands that were raised here that had a pharmacogenetic test brought to them. Can you raise your hand again? May I ask just what the clinical settings were real quick? What kind of patient and what was happening with them?
The SIP system.
And what were they being treated for at the time?
Migraine.
Okay. Depression and migraine. So both SSRI related decisions, which there's quite a bit of data behind for helping at least not select certain SSRIs. Did you guys know at that time what you wanted to do? And it's totally okay if you didn't, but when they handed that to you, what was your immediate reaction?
I went, how do I interpret this?
Was it just a piece of paper that they handed you or a PDF? Right.
Like this thick.
And you've got what? You got 10 minutes maybe to speak with this patient? And right? And you're wondering, now that this thing has been brought into my life and I don't know that much about it, what do I do? Am I liable for this information that's now been put in front of me if I make the wrong decision accordingly? And you start to feel all these feelings of anxiety, uncertainty. What does this test actually cover? Is this a reliable test? There's tons of things that I think we still have some pretty big hurdles around to try and consider what to do. I did not put this slide up because I want you to write this down. Clinical Pharmacogenetics Implementation Consortium, or CPIC. If somebody comes to you with a PDF and says, here, what do I do? That's the place that you go. And if it is not a guideline that is listed there, not 100% fidelity here, but close enough, there's likely not to be evidence that is robust enough to support you making a difference in your clinical decision making, although there may be data of lesser support to help inform some decisions. Reliable, robust clinical data on what do I do if a patient hands me a genetic test report with cytochrome P450s and a few other drug metabolizing enzymes are going to be best found there. They have some very abbreviated and simplified tables that are very clear on what the genotype is, what the predicted phenotype will be because of that, and what ramifications that then has on the decisions that will be made for that patient according to their genotypes. And if you don't have confidence there, you can call me or email me. I'm more than happy to help the University of Utah, and I do so with the Supportive Care and Oncology Survivorship Clinic, or SOS Clinic, up at HCI. I love curveball cases that get really difficult and bring in more than one pharmacotherapy case that you're trying to do. So I don't have all of the time in the world, but Ryan.Nelson at ARUP Laboratories, please email me. I'd be happy to help you. The thing that I think is important here, though, is being comfortable with not being certain on what you're trying to do and then figuring out resource-wise where to go next. And, just for the sake of how limited time you guys already have with these results, CPIC is the place that you want to go. And if you can't figure it out there, you can email me, another person within your informatics department at the University of Utah. He's going to probably hate me for referring him. But David L. Halta is a pharmacist in the informatics program here that has done a couple of best practice alerts that if you guys feel strongly within your clinic, you're seeing something in a repetitive fashion, could do an implementation project for a BPA to fire if you would like it to within your clinics. But I think that's the main thing that is important as far as results. The part about ordering, so at the U, you guys do a lot through ARUP. We offer, I think, the most competitive pricing and, in my opinion, one of the most robust tests available for pharmacogenetic testing. And from there, we can then deliver discrete results into the EMR that you can build BPAs around, as well as a static PDF in order for you to refer to and interpret. So whatever preferences are really had, we can support whatever it is that you would like to have done there. But with that, I think that's everything that is important to emphasize here for the University of Utah. For others, there's plenty of other pharmacogenetic tests. The thing that matters is that it's CAP accredited, the College of American Pathology. Their accreditation really matters for pharmacogenetic tests. Oh, yeah. CPIC, and that's Clinical Pharmacogenetics Implementation Consortium.
It still doesn't roll off the tongue.
It doesn't. CPIC, though, does.
So I apologize, I kind of wrapped up.
After, if you email me, I can get you a whole slide deck.
So I predicted this was going to happen. We're going to run out of time, which we'd have. And in respect to the rest of the program, I am going to turn it over now back to Kathleen. However, I did want to at least put this slide up here on some of the discussion topics and things to think about. Most of all, how do these test results impact prescribing in women's health? And I think what I'd love to do is perhaps do a little research. If I think of all of you in your practice, you'd want to walk away with, what are the main areas that I maybe should be thinking about whether this type of testing should be done or not? And I think, it's antidepressants, it's migraine, and like, what are the top prevalent diseases in women that have the top prevalence of drug metabolizing enzymes? What's that cross? And is there a paper out there, one paper that kind of summarizes that for women's health that maybe we could share after the program with everyone? That would be great. Okay. All right. And with that, I thank you so much for your time, and I'll turn it back to Kathleen. Okay, so we have apparently time for one question. Any burning questions from the audience? Michael.
I don't know if it's burning or not, but for all of us, our circulating levels of estrogens and androgens are going to vary over the lifespan. And how much, if any, do those levels affect epigenetic effects of SNP testing?
Great question, Joseph. I think I'll defer that to you.
Use the mic.
Yeah.
I'm not sure I have a great answer. So, unfortunately, I'm not sure I have a great answer. I mean, your SNPs will be predetermined at birth, right? So that won't be changing. I mean, epigenetics will be changing based on diet, environment, all those sorts of things. How that directly affects estrogen, I'm not entirely certain of the literature there. So unfortunately, I don't have a great answer. Sorry.
Conceptually, though, it's a good question.
Yeah.
Right. How does that change and how does that impact SNPs? Highly variable. Okay. Yeah.
Yeah.
That would have been a good, safe answer. Highly variable. Yeah.
It's other burning questions.
Yeah.
Because this is such an important area in women's health, and for providers, it's like critical.
It will continue to change. So,
Yeah.
Thank you.
Thank you so much. Great.
Our next speaker is Dr. Kary Woodruff, and she is has a PhD in nutrition. But what's really cool, a master's in sports nutrition. She has a degree in psychology, and she directs the master's program in nutrition and dietetics here at the University of Utah, and oversees the sports nutrition track. And she's going to help us understand weight bias in providing weight neutral care in healthcare, which I think, weight is such a big deal, and we're in the middle of an obesity epidemic in our country. So even in Utah, we have some.
Thank you.
Thank you so much.
Well, thanks for having me. So as mentioned, my name's Kary, and I direct our master's program, as mentioned, in nutrition dietetics, which just means that we graduate future dietitians. And this topic is very near and dear to my heart. Let's see. Because I worked for about 10 years as a certified eating disorder dietitian. And I worked with patients, initially athletes with disordered eating and eating disorders. And then eventually my practice became primarily all patients with some form of disordered eating. And I felt a lot of tension because at the time I was a full-time practicing outpatient dietitian at Intermountain Health. I was at Tosh at an orthopedic hospital. And I was part of Intermountain's lead team for the Way to Health program, which is a correlate of the New You program here at the University of Utah. It's a 6 to 12 month weight loss intervention aimed at increasing healthy lifestyle behaviors, decreasing body weight. And I worked with, I'm sure, hundreds of patients to help them to lose weight in what we hope is a meaningful way. And then I would put on my different hat and I'd go to my office and I'd work one-on-one with patients with maybe a clinical eating disorder. And I felt like a lot of times there was this tension between what we were asking our patients to do in the context of weight loss, and then how we're addressing and treating our patients with eating disorders, talking about intuitive eating and all foods fit, no good foods, no bad foods. But then at the same time, weight loss, saying we'll eat more of this and eat less of that. And it just felt like there's a lot of tension there. And so it got me curious and I started asking more questions. And I certainly don't have all the answers, but I'm coming to learn what are some of the better questions that we can be asking with this tension. And my goal for today is to talk about some of the challenges that we see with dieting practices. What are some of the adverse effects of dieting? Because it can be seen as a sort of panacea for health. And we know that's not true, but to recognize what are the potential harms when we're recommending weight loss. And then we'll put in the context of how weight loss is increasing and promotes weight bias and weight stigma. And then my hope is to actually have some practical advice of how do we decrease weight bias, weight stigma in the context of weight management. I'm not anti-weight loss, nor am I someone who, I don't fall on either end of the spectrum. I think there's some middle ground that we can find. Can I ask for a show of hands, who here works with patients in any form capacity? If a patient, maybe you're not addressing weight loss, but you're working with patients who are trying to lose weight, any form of weight management goals? Okay, just helps me to see where our audience is at. In the first half of my presentation, I'm going to be talking about diets. So I first want to broaden that title to say self-directed diets. And that would be any form of likely short-term approach to try to lose weight. It can include intermittent fasting, Optavia shakes, time-restricted eating, ketogenic diets. Now, certainly many of those approaches are lifestyle behaviors for some of our patients, but for other patients, they're more temporary forms of weight loss. And so to try and disentangle that. And so these are often very alluring, very attractive. FOMO is a common reason, fear of missing out, but lots of individuals are going on diets. About 45 million Americans will go on a diet in any given year. And that's just in 1 year. That doesn't speak to lifetime prevalence. The diet industry is about a $33 billion industry. And they're really, really tempting for why individuals try them. And lots of inducing factors as well. There's certainly media pressures, whether we're talking about social media, more traditional forms of media, and also looking at why they're seen to be so successful. We have confirmation bias, which says that what we see what we confirms what we believe. And so if we see someone losing weight, we think, yes, this diet works. Law of very large numbers. If 200,000 individuals lose weight on the celery juice diet, well, that's in larger context, not many people, but it can seem like it's a lot of people who are losing weight on the celery juice diet. And yes, there is a celery juice diet. But to look at the research, and many of you probably know a lot of these statistics, but I think they're worth mentioning when we think of some of the long-term effects. And if you can't read, sorry for the small type, it says, if I gain 20 pounds, it will give me the motivation I need to stick to my diet. And that speaks to some of the weight cycling that we see, and we'll talk about. And there are adverse health effects we see with diets. There was a recent study that looked at the top 4 most common diets, and they found that 0% met 100% of the RDA, recommended dietary allowance, for any of the 27 nutrients that were examined, in part because they promote such a low calorie intake. It's really hard to meet your nutrient needs on such a low calorie diet. There are psychological effects that we see from dieting practices: increased irritability, depression, fatigued, decreased motivation. And this is certainly not an exhaustive list. And yet I think it's also worth mentioning that last point there. I tried to highlight that in bold, but one of the biggest predictors of future weight gain is dieting. So we know that once someone goes onto a diet, they're significantly more likely to gain weight. And that's not what we want for our patients. So when we look at the research, we see that most individuals are gaining the weight back, and actually up to 2/3 of patients who lose weight are actually going to gain back more weight than what their starting weight was. And again, just speaking to, in what area of medicine would we recommend an intervention that has a high likelihood of increased adverse effects. And it promotes a cycle of what we call weight cycling, of losing weight, gaining weight, and that cycle. And we know that's not what we want either. There's some controversial Some of the research is controversial in that it's not very clear cut, but what we think are some of the adverse effects of weight cycling include increased risk for cardiometabolic harm, increased risk for type 2 diabetes, increased mortality. And again, that's the effects of that losing weight, gaining weight, losing weight, gaining weight versus remaining weight stable. Weight loss isn't easy to maintain either, and actually that's really where the crux, I think, comes in. We have evidence-based practices, which I'll very briefly summarize, for how we can help our patients to lose weight, meaningful weight, meaning 5 to 10% of body weight. We don't have great interventions to help sustain weight loss once it's been lost. And there are a lot of reasons for that. There are a lot of environmental reasons. There are a lot of public health policy type factors that contribute to weight regain. And then also just physiological and biological reasons. The body really fights weight loss and fights that maintenance of having a lower body weight. And there's a whole host of reasons. I have, for my hour-long slides, I go into some of the biological, physiological reasons, but there's a lot that fights against us when we're at a lower body weight. And so when I was in my search of looking at healthy weight loss interventions, this comes from the Cleveland Clinic, and, not to be Dr. Google here, but, if someone's looking at how do I lose weight healthfully, well, this comes up from the Cleveland Clinic, and it says, exercise regularly, eat a variety of unprocessed or minimally processed foods with moderate portions. And I think this is such a disservice to our patients. I think it oversimplifies how hard it is to lose weight, and it certainly doesn't capture how hard it is to maintain weight loss. And it results in our patients feeling like they're not going to be successful, right? Because if it were that easy, then wouldn't everybody be at a healthy weight? And we know that's not the case as we look at just public health, looking at the numbers. And so I think first and foremost, just helping our patients to understand how challenging this is. And when we're having these conversations of, if you want to lose weight, let's talk about it. Let's talk about what are the risks, what are the potential benefits, and what is this going to look like for you and your health? I'd like to introduce some terms here, and these may not be new to you, but we have size oppression. This is the experience of harassment and discrimination for being or for not being a specific weight. Weight stigma are negative weight-related attitudes, behaviors, judgments towards individuals who are at a higher BMI. And then weight discrimination is the unfair or unequal treatment of people because of their weight. Weight stigma and weight bias can be used interchangeably. They're not exactly the same, but for the purpose of this today, we can use them synonymously. And then weight discrimination is that experience of unfair treatment. And I wish I could say we were immune to these concepts in healthcare. Unfortunately, we're not. So first, I'm going to define what we can call the weight normative approach. And this still continues to be the majority approach to weight management in the context of healthcare. And this is more the traditional approach to weight. And what this says is that an individual's weight is the result of their poor dietary choices. It's a proponent that individuals have control over their weight, and so therefore obesity is a matter of personal responsibility. And so the consequences of having these beliefs is that it does perpetuate anti-fat prejudice and weight bias. Now, weight discrimination, and here's where when we look at studies that look at the effects of higher BMI, the effects of being in a higher BMI and adverse outcomes, I really encourage you, as you're looking in this literature, if you ever are looking in this literature, to really look at the study methods. And what you'll see is very, very, very few research studies that have examined the effects of being at a higher BMI or being obese have controlled for the experience of weight discrimination. And so if you look independently at someone who experiences weight discrimination, there are significant adverse health effects to that experience. And it's similar with other forms of discrimination. It's considered probably the second or third most prevalent form of discrimination here in the United States. But it does increase allostatic load, that cumulative burden of stress in one's life, which we know significantly decreases mortality. It increases suicidality, psychiatric substance abuse disorders, cardiometabolic health, and other markers of inflammation. And so just irrespective of adiposity, but that experience of weight discrimination increases all of these adverse effects, which we also connect with having increased adiposity. And so unfortunately, we just haven't teased out in the weight loss literature to say, well, someone has, a BMI of 40, their body fat percentage is whatever it may be, and therefore that's causing their increased worsening outcomes in cardiometabolic health. But have we controlled for their experience of weight discrimination? That might be contributing to those adverse effects as well. And it's not to say that there aren't lipotoxic effects of having increased adiposity. It's just when we look at the literature that's saying, here's what having increased fat results in, we haven't done a very good job of controlling for other confounding factors. We also know that experiencing weight discrimination is also much more likely to result in decreased physical activity and poor eating habits in of itself as well. So again, there's a lot that's going on that we're not always recognizing. And then the experience of weight discrimination and experience of weight stigma in healthcare, unfortunately, is very poor, or at least is very high, I should say, resulting in poor outcomes. So in one very large sample of women who have a BMI of greater than 30, I don't use the word obese a lot. I tend to use frame it in terms of BMI. But 69% reported experiencing weight bias from physicians, 46% from nurses, 37% by dietitians, 21% by healthcare, other health professionals. Psychologists tend to attribute greater pathology to patients who are living in a larger body. And that we know that unfortunately in a 2020 review found that younger healthcare providers actually tend to exhibit greater weight bias and stigma compared with older healthcare providers. So it doesn't seem to be improving. When we look at the harmful effects of weight stigma, this shows, I think, just a nice pictogram of what's going on. So someone experiences weight stigma and discrimination, that increases their allostatic load, that experience of chronic stress in their lives, that increases cortisol, increases eating, results in weight gain, weight regain, and thus that cycle becomes perpetuated. Now, here's where I get to say, let's not throw out the baby with the bathwater. I'm not anti-weight loss interventions. I think we just have to be very thoughtful with how we're approaching our weight management interventions with our patients. I think there are strategies we can help to increase the healthfulness in our patients, may or may not result in weight loss, but it's more how much of a focus is weight in the context of other factors. So very, very quick summary slide. The intention here is not to say what does work in weight management, that would be a separate discussion, but just to highlight that there are evidence-based practices that we know of to help support lower body weight or a decrease in body fat among our patients. Again, recognizing that even a 5 to 10% body weight loss, maybe even 3 to 5% can be clinically meaningful in improving blood pressure, improving blood lipid levels, glucose levels, etc. And so here's just really a summary of what we know to be effective. All of this needs to be individualized. There is no one size fits all approach, but there are ways that we can individualize these components to help support lower body weight. And then the Academy of Nutrition and Dietetics had a really nice article I'd be happy to send out that compared self-directed diets. So the individual who goes on the celery-reduced diet, who goes on cleanses, juicing, time-restricted eating as a way to lose weight quickly, those self-directed diets, how that increases risk for eating disorders and disordered eating, whereby alternatively promoting evidence-based weight loss interventions that is supervised, ideally provided by a registered dietitian in conjunction with a medical provider's primary care, that we can actually help to increase healthy lifestyle behaviors and increase coping skills, increase behaviors that promote health, potentially some weight loss in the context of being in a larger body weight. And so it's more about how we're approaching these patients versus just looking at the weight. So compared to the weight normative approach, where the focus is on weight, I really love and have really embraced a weight inclusive approach to healthcare. So instead of having the emphasis being on weight and the focus on weight loss, the focus is on what the patient has control over, and that's their health related behaviors, right? So how do we help our patients to increase their intake of fruits and vegetables and whole grains when they have access to these foods? Certainly access is a big point that needs to be addressed. Denounces weight stigma, and recognizes that there are so many policy and environmental factors, as well as genetic factors, that contribute to body weight and body size that are that are very much out of our patients' control. So weight inclusive care is an assumption that everybody is capable of pursuing health and health and well-being independent of weight, given access to non-stigmatizing health care. So there are some commonalities with the weight normative approach. Certainly for individuals who focus on weight, they're still recommending some of the same behaviors of healthy eating behaviors, stress management, sleep, all of the lifestyle behaviors that we know to promote health. And so there is that overlap between weight inclusive care and weight normative care. The difference is on the importance and emphasis placed on weight. So is the patient walking into the clinic, the first thing they see is the scale, they're being weighed, and they're talk about, well, how much weight did you lose this week? Versus the patient comes into the office, they may or may not be weighed. They come into the provider's office and they talk about, okay, well, what changes, what worked this week, what didn't work, how are your eating behaviors this week? And so focusing more on the behaviors and having not having a focus on the weight. It is not an assumption that everyone is healthy at every size. And I'll talk quickly about the health at every size approach, but it doesn't propose that everybody is healthy at every weight, nor is it anti-weight loss. And so I'll talk about some of those nuances. Looking at alternative approaches that also provide a more weight inclusive approach. Can I see raise of hands? Has anyone here heard of the health at every size approach? Okay, so there are some individuals. HAES is a shortened term, HAES. So I do not identify as a HAES-informed provider, but there are many medical, dietitian, other healthcare providers who do identify as health at every size informed providers. And so to understand what that means, they promote weight inclusivity, which respects diversity in body shape and size, and reject idealizing or pathologizing specific weights. Promote practices and policies and personal behaviors that promote health that we know to be very helpful, of stress management, sleep, physical activity for enjoyment, and eating behaviors. Eating for well-being, which really summarizes nicely an intuitive eating approach. They're not synonymous, but they work very well together. So we eat for hunger and satiety and to meet our nutrition needs, as well as for pleasure, and not eating for external factors of what my weight may or may not be. Respectful care, meaning that we recognize our biases and we work to continue to address our own biases and provide respectful care. And then life-enhancing movement. So how do we help our patients to move their bodies in a way that's joyful, that they is something that helps support stress management and helps to support energy levels and helps them to feel better overall versus getting on the treadmill to burn calories. So these are some of the core tenets of a health at every size approach. It should not be assumed that the health at every size approach says that everyone is healthy at every weight. Rather, the health at every size approach says that not everyone may be at a healthful weight. However, attempts to lose weight may increase harm more than the weight itself. And therefore, is the health at every size approach would suggest that weight loss is not appropriate. So there have been many studies to show that a weight-inclusive care can improve health outcomes. Here's just one example of a randomized control trial that compared a weight loss intervention group with a weight-inclusive approach that included intuitive eating as its nutrition intervention and address other lifestyle behaviors. And they found that the weight loss group did lose some weight, though the amount of weight loss was pretty nominal, but it was statistically significant. They found that the weight inclusive approach improved intuitive eating. They also improved their LDL cholesterol levels, saw decreases, and both groups saw increased intake of fruits and vegetables, increased physical activity and other healthful behaviors. So we know it can help to increase health-related behaviors. And then just some general strategies, sort of a starting point for how we can increase the weight inclusivity of the care that we're providing. The Harvard Implicit Weight Bias Test is a great starting point just to know what your own weight bias may be. I have all my students take it, and even students who feel very strongly that weight loss is not appropriate in some contexts, a lot of providers do find that they still have some weight bias, and so it's just helpful to know where we're at so we have a starting point. Recognizing the role of cognitive biases, so the fundamental attribution error says that we tend to over attribute individual personality factors for other individuals for their success or lack of success. So we might be more likely to say with our patients, they're not losing weight because they're not, they don't have enough self-control, they're not determined enough, they're not motivated enough, and then we underemphasize the role of other external factors, societal, environmental factors. And yet, interestingly enough, for ourselves, we actually tend to over-attribute external factors for when we're not being successful with something, and we attribute internal factors. Anchoring bias. So I think in healthcare, this is a really important bias to consider, because the anchoring bias says that the first information that we may have learned on a topic may emphasize or more play a greater role in our belief system, that initial piece of information. So for me in, graduate school for nutrition, for physicians in med school, if some of the initial, information you learned about weight is that it's all about self-control and discipline and what, personal attributes, that anchoring bias is that information tends to influence us even many years later. Acknowledging our own privileges, even if it's not just privileges regarding some of the more overt privileges, but even thinking about privileges we don't always recognize, including weight status. And then increasing or continuing to focus on health-related behaviors, and then focusing on the patient's values. There are so many stories of patients who go to healthcare providers for an ear infection and they're told to lose weight. And it happens, and it sounds ridiculous, and it happens. And so, when our patients come to us, why are they coming to us? Are they coming to us because they're concerned, about this cough that they've had? Or are they coming to us because they want to lose weight? And so just asking them, how can we help them, and how can we keep the focus on what they're asking us to help them with? This comes from the American Diabetes Association, and is just a sample of weight normative language on the left column compared with more weight inclusive language on the right-hand column. So instead of saying eat less, move more, we might say, how do you feel about your eating behaviors now? How do you feel about your weight? Instead of saying, I think weight loss would be helpful for you, we could say something like, one of the things that we know is that weight can influence our outcomes when it comes to diabetes. Is this something you'd like to talk about? The patient may want to talk about it, they may not want to talk about it, and that's where we respect their wishes. But just some samples of language that we can use. Even just thinking about our physical spacing, I think the clinics here at the university have gotten certainly much better at how we provide more inclusive care. But even some of the details of thinking like what sort of artwork is being promoted in our clinic spaces. Does the artwork tend to promote more of the standard smaller body size individuals, or does it embrace body diversity? So thinking about our physical spaces. Having a weight inclusive network. So do we have other providers, dietitians, medical providers, therapists that we know that provide weight inclusive care, and have that referral list? Some resources. And then finally, I just like this little
cartoon here, and it says, every time I go on a diet, I lose my mind. Unfortunately, it doesn't weigh very much. So I think I'm out of time, but thank you for having me.
Such an important topic. Any one burning question for Dr. Woodruff? Yeah. So just shout it out.
Okay, I'll try to be brief. I'm a pregnancy doctor. Can you talk about gestational weight gain, which in my experience is universally frustrating and challenging, particularly because we have a set of recommendations, but folks just struggle to have any measure of control over it. So I've sort of moved to a style of mostly ignoring it and not really focusing on it. And so I don't know if that's right or wrong, though, and I'm curious to get thoughts.
Yeah, I mean, I'll speak. I talk about this with my students, and what I say is know your audience first and foremost. I think, there are going to be patients who are going to be obsessive about their weight gain during pregnancy. And so I had a physician here for all three of my pregnancies, and luckily she was just very gracious with, I gained a lot of weight in the first trimester, but then I didn't. And my overall weight gain was within the recommended weight gain. And if she had overemphasized in that first trimester my rate of weight gain, it would have sent me into a panic earlier on, I think, in my life when I was younger. So know your audience. If it's someone who you think doesn't have a lot of knowledge of healthy eating patterns, then I think just gently, if there's a trend, not just between visits, but over time, you're seeing a trend of unhelpful weight gain, you might say, is this something that you'd consider talking about a dietitian with? Because I know you care about the health of your baby. And so we can find ways to help you to eat in a way that might support the health of your baby as well. And so just recognizing what is their health literacy and what is their knowledge of nutrition. So for the people who already know, just being gentler, I think, on that. But it's tough. I don't know if that's helpful or not, but.
Thank you so much. Our next moderator is Dr. Michael Varner, who's a professor emeritus in the Department of Obstetrics and Gynecology.
Thanks, Kathleen. I noticed on the agenda that there wasn't a specific title for this session. As it was being planned, it was going to be called "It's Local Legislative Updates." And just as a brief introduction, those of you in the Health Sciences Center may get some of you get a monthly email about something called the Leadership Live Stream session. It's I think third Wednesday in the middle of the afternoon, which nobody who's seeing patients could ever go to. But I happened to be listening to it in March, and one of the presentations was by a guy named Jason Perry, who's the health sciences government relations person, and he gave a quick overview of the Utah legislative session. And it turns out that the Utah legislative session starts on the fourth Monday of January, and it goes for 45 days. And this year, and it's amazing what they get done, for better or for worse, in that interval, but this year they set an all-time record for introducing 934 bills, of whom 591 were passed, half of those in the first week. And he estimated that of those 934 bills, the average public discussion of those was 11 minutes. So you might ask, how can we possibly keep track of all the stuff that's going on there? We don't have the answers in the next half hour for all of that, but we have, I think, some answers on at least two topics remarkably germane to this forum: transgender health and reproductive justice. So in the interest of time, I'm going to take the liberty of introducing both speakers quickly and to tell Jess Sanders that in about 10 to 12 minutes to kind of ease to one side of the room or the other. But our first speaker is Nikki Mihalopoulos, who's a professor of pediatrics. She was recruited actually back to Utah to head up the adolescent division. I don't think I actually want to know how many years ago that was at this, just a few, but she's, for any of us who have ever had the occasion to deal with adolescents, there's no shortage of opportunities to either back down or to address the issue head on. Nikki turns out is not one to back down from challenges. And in the adolescent medicine clinic, she's really been the go-to person for gender management and support. And so she's going to talk to us about transgender health and the context of the legislative update. Our other presentation is from Jess Sanders, who's an assistant professor in the family planning division and the OBGYN department, who has an enduring interest in fertility, reproductive health, has already led several Utah-based contraceptive initiatives, and approaches her research and advocacy from a human rights lens. And she'll be talking about reproductive justice updates. So, Nikki.
Thanks for that very nice introduction. So my disclosure, not a lawyer, but I like to call myself a junior lawyer, because I feel like I've learned so much about the legislative process, how to be an advocate, how to influence policymakers, how to try not to get really, really angry, and appreciate the very positive people who are on the Hill up at the legislature, who teach me how to be a better advocate and a better speaker. And so I give all of those kudos to Troy Williams with Equality Utah. He is an amazing human. And if you have an opportunity to spend time with him, please, please take it. So let's see, why didn't that advance? Do I need to use this one? Okay. All right, so from 2019 to 2024, Utah has passed some really phenomenal laws. Some address hate crime, some address name and gender marker change, conversion therapy ban, school policies, and healthcare access as they relate to transgender and gender diverse people or non-cisgender people. So among those laws that protect, we actually have a hate crime law that's pretty great, that protects individuals based on gender identity and sexual orientation. We do have a name and gender marker change law, which allows, I have this under Protect. Equality Utah says this is a space that needs work, okay? I decided to embrace the positive here and say, at least we allow people to change their name and gender marker. There are some states and countries that do not. And then we have a conversion therapy ban, where we banned conversion therapy for minors. So I wanted to just kind of look into these a little bit. The hate crime law was Senate Bill 103, and it became effective on May 14th of 2019. It was proposed by Senator Dan Thatcher from West Valley City, and this is a law that specifically protects against crimes that target individuals or institutions on the basis of personal attribute. So all of those in that list are considered personal attributes, and someone cannot commit a crime against someone based on one of those personal attributes and get away with it. Okay, so we have a law that says if you do that, it's really severe and it's actually a felony. And so it specifically includes gender identity, sex, and sexual orientation. Then in this year, a sneaky thing happened. So House Bill 234 modified the vital record information without anyone noticing. And they said, you can change your name and gender marker on a birth certificate. However, you must be at least 15 years and 6 months of age to do that. So for a 12-year-old who has been identifying as the opposite gender and is been going by a name different than their birth name, it might start feeling really uncomfortable when they hit junior high and the school roster isn't going to put their preferred name and gender marker on the roll. And there's a substitute teacher who goes straight off the roll. And so they aren't going to be able to change their name and gender marker legally. So while this is sort of positive, it's still, we need some work. And the other piece is that there must be a guardian ad litem appointed for that minor child. And the cost of the guardian ad litem actually gets passed along to the parents. So we've got some work to do here. We also do amended birth certificates. So if you have to present your birth certificate, then someone will see that your sex assigned at birth was different than how you look now. But I'm choosing to embrace the positive on this one. So the other things that are necessary for modifying or changing a name and gender marker is that there needs to be a letter from a healthcare provider that provides this information that states that someone has transitioned from their sex designation of the biological sex at birth to the sex sought in the petition. They outwardly express that gender or sex for at least 6 months, and that they suffer clinically significant distress or impairment due to the current sex designation on the birth certificate. And so in our clinic, in the adolescent medicine clinic, which is located at Primary Children's Hospital, we provide a letter that specifically has all of this legalese in it, and hopefully it's making the process easier for kids and families. And then the other thing I want everyone to take away from this is there are court fees, but there are fee waivers. But people have to apply for them in order to get the fee waiver, and most people don't even know that exists. So as you talk to friends, family, strangers, loved ones, whoever, please encourage them to apply for a fee waiver, because I get a lot of families telling me that it's too expensive, but they may actually qualify. A very positive bill that was passed was House Bill 228, and it made into law the prohibition of therapists from subjecting youth to conversion therapy. So in January 2020, the state adopted a policy barring conversion therapy for minors, but then in 2023, so last year, Governor Cox signed that bill that bans conversion therapy. So that's great. Then we moved to laws that restrict. And in the last 2 years, these have been horrific. They're not as terrible as other very conservative states, but they are affecting the health and well-being of the kids of Utah and in our neighboring states. So one of those laws is affects school policy regarding transgender student access to facilities and participation in sports. And then healthcare access are laws that impact transgender individuals seeking gender-affirming care. So let's look at those. So in 2022, House Bill 11 was proposed by Kira Birkeland from Morgan County. So, oh my gosh, this is my bias creeping in. I'm sorry. I really have a hard time with this particular representative, and I'm trying to find my positive space here, okay? So effective July 1st of 2022, her bill went into effect that banned transgender girls from participating in girls' sports in Utah high schools. Big surprise here. There are like less than 5 transgender girls participating in girls' sports in Utah's high schools, but she wanted to make sure all of them were not participating. And the families, the 2 families who were, decided they were going to sue the state. And in that suit, Judge Kelly created an injunction. So a month after the bill went into effect, which allows these girls to submit an application that goes to review by a state-appointed sports commission to determine if that girl can participate in a Utah High School Activities Association girl-specific sport. And then if they approve, then there's an annual review to determine if they can continue to participate. And so basically what happens at that review is that there are a bunch of people who are inadequately informed to be reviewing the information. There are like 2 people who I think are okay, and there are 6 who are probably need to be better informed, who ask questions like, now tell me why you would like to run in girls' track. Why do you want to do that? So I went home and I asked my own 11-year-old, I said, why do you want to play girls soccer? And she said, why are you asking me that, Mom? I said, I just want to know. She said, because I want to kick some butt, Mom. I was like, holy crap. If you said that to the sports commission,
boom, big no, right? No, you don't get to participate. But so these girls are in a rough space when they go in front of the commission. But we still have the injunction in effect so that they can ask the commission to review their case and decide if they can participate. Right now, 1 can, 3 cannot. Okay, so then just to like really hit hard, this year, Representative Birkeland said, we need to protect girls in bathrooms and changing rooms where really bad things are happening. And she sponsored a bill called Sex-Based Designations for Privacy, Anti-Bullying, and Women's Opportunities. This sounds amazing when you read it. Like, what an awesome title, right? Sex-Based Designations for Privacy, Anti-Bullying, and Women's Opportunities. Amazing. Okay, so it got passed, and it really affects public school bathrooms, changing rooms, and locker rooms in K-12 public schools. So a transgender girl can use those spaces, but only if a healthcare provider gives them a letter to take to the school to say that they should be allowed to use the bathroom that aligns with their gender identity. Okay, so for a kid who maybe got in on I'm running out of time here, sorry, I'm really passionate about this, on the name gender marker change before this last iteration of the bill went into effect, they maybe have been flying totally under the radar. But as soon as there's this birth certificate piece that comes up, now they might be seen. And now it becomes this painful space for them. So we have work to do here. But the other space that this affects is changing facilities in government-owned buildings, typically recreation centers, so like community rec centers, or universities, so that these spaces are operated by cities and counties. The most important things to take away from this is that there is no legal consequence for transgender or non-binary people in Utah who are using restrooms. It's only changing rooms. So when a toilet is in a room that is also a locker room or a changing room where people are getting naked. And there are only penalties for people who use the bathroom for improper purposes or who engage in prurient behavior. And then it does not apply to bathrooms and changing facilities in places like restaurants, hotels, theaters, malls, blah, 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 any space that's privately owned. Okay, so we need to spread the word because there's so much confusion around this law and what's involved. And John Dougal, who is the Utah auditor, who is in charge of investigating complaints about how this bill is being enforced. Just yesterday, there were news articles about how he has already received more than 10,000 complaints, most of which are fake complaints from people like Joe Mama and Pearl McClutch. And those are some of the benign names. Okay, and he has it out for Representative Birkeland. Okay, the last thing that I have is healthcare access. This directly affects the kids who are in our clinic space. And so Utah is not alone. We are one of 22 states that have either banned or restricted gender affirming care for transgender youth. And so this is the map of states who have banned care. It is very similar to Republican states. So healthcare is very much a political experience now when it comes to this population. So Senate Bill 16 was passed on January 28th of 2023 is when Governor Cox signed it. So that was a Saturday morning when he signed the bill and it went into effect that day. And so what that said is that anyone who has a diagnosis of gender dysphoria documented by a healthcare provider prior to that date, and who is established with the provider, not a provider, because that would mean that we can't have a team of providers. So, but who has established care with the provider for at least 6 months can receive puberty blockers or hormones as part of their gender affirming care. Now, the next piece that went into effect was on January 1st of this year. The provider who's prescribing, as well as a mental health provider who the patient must see at least 3 times, need to have a special transgender certificate from the Utah Division of Occupational and Professional Licensing. It takes 40 hours of transgender youth specific CME to get that certificate over the course of 2 years, which is very complicated because there's not a lot of hours of transgender youth specific CME. And there are a handful of us who have that in the state of Utah now. Okay, and then in summary, this is from Equality Utah. This is their transgender protections and what they think is really great, where transgender Utahns are treated equal. So hate crime laws, housing non-discrimination, employment non-discrimination, and protection from conversion therapy. And where there's still work to do are all of those other places. And I thank you for your time. And as an optimist, growth means change, and change involves risk, stepping from the known to the unknown. And so hopefully we will step into the unknown gracefully.
Well, and I have to imagine there will be some overlap in terms of the maps that we are showing between my presentation and Nikki's. So I'm going to do just a little bit of an update on family planning and abortion in the state of Utah. So I hope that at this point everyone is aware of the Ascent Center for Reproductive Health. We are a center, interdisciplinary center that's in the OBGYN department, but have partners all across campus. And have very committed to elevating the health and well-being of our community through essential sexual and reproductive health care, education, and advocacy. So lots of things going on there. So quickly, the majority of my presentation is going to be around the reproductive rights and reproductive health part of these circles, but I want to just introduce the framework of reproductive justice. So it's the idea that everyone has the human right to decide if and when to have a child, decide if and when if they will not have a child, and their options for preventing or ending a pregnancy, parent the children they already have with the necessary social supports and safe environments, and demand sexual autonomy and gender freedom for every human being. This is a framework that was created by a group of Black women in the South doing intersectional human rights work to expand the conversation and efforts beyond kind of the white feminist approach. So again, it's very intersectional, and I will just be talking about the health and legal part of it. So our team has done and big shout out to the whole team. A lot of these slides are drawn from my colleagues, and thank you. So our team has done these large-scale contraceptive access initiatives, in large part as demonstration projects for needs and policy changes that could be implemented here in the state of Utah. So the Her Salt Lake program provided over 7,000 individuals with contraceptive access, with no-cost contraceptive access, and followed them forward for 3 years to understand some of the individual level impacts of contraceptive access. Family Planning Elevated had a contraceptive access program that worked with health systems. And so we are able to really build this network of providers across the state who understand the importance of person-centered access to contraceptive care and become a resource with really strong connections to our team. And also we provided over 19,000 individuals with no-cost contraception. So some of the policy changes that have happened in some part based on the data that were collected during those projects, where we were able to educate and support Utah's Medicaid family planning waiver, which after a number of years of having lots of conversations and not getting passed, it was passed during the 2023 general session alongside extended postpartum coverage under Medicaid. So as of January of this year, anyone on pregnancy Medicaid, this does not apply to emergency Medicaid, but pregnancy Medicaid can have 12 months of continuous coverage postpartum. So that's already in effect. The part where contraceptive services and family planning services are covered were filed under a different waiver, and so are currently waiting in the federal CMS, waiting for federal CMS approval, but we're hearing that summer 2024 is kind of the sweet spot. But Ascent is committed to providing implementation support to our clinical partners and is working closely with the Medicaid program. So family planning services that will be covered for anyone up to 185% federal poverty under this waiver program include family planning visits, FDA approved all methods of contraception, as well as STI related care, contraceptive management, patient education and counseling, testing, and then all of these services are provided are exempt from cost sharing. So apart from the policy changes, we've had a lot of programmatic expansion that's happened around contraception in Utah and with our program. So we've done quite a bit of community-based EC expansion, emergency contraception expansion. So currently in Utah, pharmacists are able to provide and dispense any self-administered hormonal contraception. EC has long time been over the counter, especially, or levonorgestrel emergency contraception has been over the counter. And so we've been working with those over the counter methods and our community partner organizations across the state and have dispensed over 2,500 doses. And then another exciting piece of this EC expansion project is campus access. So at the U, we actually have 2 vending machines, and the availability of EC is expanded through the vending machine program, and people can access that with their U card. It is for folks over 18 years of age, but EC is available over the counter for regardless of age and through community partners, regardless of age. But because we're at a state-funded institution, that age requirement is there. And through the University of Utah Pharmacy. So across 16 pharmacies, we're providing no-cost emergency contraception and no visit requirements. So through a standing order that's been made, you have the ability to request no-cost emergency contraception through MyChart, or you can have someone walk into a pharmacy and request no-cost contraception. So other contraceptive resources I saw there was a poster for the rapid access contraceptive clinics, which is great. And then our team is continuing to do training and technical assistance. We have our annual contraception education program happening in November, so save the date. So now I'm going to get into a little bit of abortion. Conversation around abortion policy. So as I'm sure you are aware, in June of 2022, the US Supreme Court overturned Roe versus Wade, which returned the ability for states to decide the legality of abortion individually. So nationally, abortion volume was actually higher in 2023 than in 2022. And this has been captured through a number of different data collection, but We Count is a kind of real-time ongoing report, and they just put out their 6th report. And so we're able to see kind of which states are changing in volume. And as you would expect, states that lost legal status of abortion, the volume decreased significantly. And those neighboring states where people were accessing, we saw a volume increase. And so everyone, no matter where you live, has been affected by this. 14 states had total abortion bans for the majority of the 18 months since Dobbs. And most recently, Florida's 6-week ban went into effect. So Utah, this is our legislative timeline around abortion since 2019. So there's been a lot of activity. And I'm going to just highlight the current standing of abortion in Utah is that people can receive abortion care in Utah for any reason until 18 weeks gestational age, and then after 18 weeks with limited exceptions. And this is because there is a current injunction that is kind of we're a holdout, right? We had a trigger law that went into effect in 2020, or that was passed in 2020, so that when Roe fell, the state was able to say, okay, the trigger goes into effect, abortion's illegal. That was only the reality for about a day, and then the injunction went into place. And so there was also a clinic ban that passed, which delicensed any clinics, which the majority, 95% of abortion care happens outside of hospital settings. And that ban was also enjoined during that same hearing. And then in 2024, they actually repealed that because the legislators felt that it was complicating the Supreme Court's decision and delaying it. So we have 2 potential outcomes. We are in a very watchful time. The Supreme Court oral arguments in the state were heard August 8th. It was right after the boundaries, the redistricting was heard. And so we're waiting on any sort of decision to come out. But there's two potential options. Abortion remains illegal in the state. It's found to be unconstitutional. This will likely result in a challenge by the state legislators to change the Constitution in a future legislative session. And then the other option is that abortion becomes illegal. And this will likely result in a citizen initiative or ballot initiative to protect abortion access. Either way, it's a very tenuous space. And it's just important to kind of stay vigilant. And so the ways that we are doing that, we have a post-row task force within the university that was actually sparked during a COE symposium 2 years back, right after the leaked draft opinion came out, when Lisa Harris, who joined us as a keynote speaker, and was able to kind of help our group flesh out what it meant to hold accountability, to make sure that we are documenting both harms and potential impacts, and to be prepared for this. So our operational subcommittees include clinical care, clinical education and training, campus community, public education, communication and engagement, data collection, legal guidance, and provider advocacy. So the areas of university support that we have really focused on over the last few years include where we're still continuing to work toward university-funded statewide or university-supported statewide no-cost contraceptive access initiatives. A clear commitment that the institutional will support trainees, support for all U of U employees in accessing the care that they need, commitment to train medical students, and then support on the Hill and with these policy conversations, and continuing to make sure that we're supporting policy through research and education. I also want to highlight some examples of the great research that's going on. Our second-year fellow, Alex Woodcock, conducted a study looking at the effects of the Dobbs decision on OBGYN graduating residents and where they were planning on going. And so, unsurprising, graduating OB residents report a decreased desire to practice or pursue fellowships in states with abortion bans. And then acknowledging that there is this risk of these types of extreme policies impacting maternity care and wait times and things that impact everyone. Our team also did a landscape analysis to see, especially when the policy to move all abortion-related care into hospitals came out, to see if hospitals were prepared to take on this additional charge. And we followed the methodology, or we followed kind of the lead of this group in Oklahoma, and found that, unsurprisingly, our hospitals were not prepared, and there was a lot of uncertainty around if and when and how they would be able to provide care for obstetric emergency and urgent situations. The good thing was, unlike our neighbors in Idaho, our hospital settings were prepared and understood that ectopic treatment was covered and protected, but they had in other more complicated vignettes, there was a lot more uncertainty. So one of the things that's coming down the pipe is our group has a research and implementation program that we're quoting Access Elevated, but it's committed to the sustainable abortion care environment. So it operates within 8 research and programming components that map onto the sustainable ecosystem, and really to the end goal of, regardless of the legal status of abortion in Utah, we want our research and implementation to support resilient local stakeholders and systems that are actively accountable and committed to comprehensive reproductive health care. So some other ways to stay involved and get engaged. We have, if this QR code goes to our provider network, which Our fellow in the maternal fetal medicine program has been helping do a regular newsletter to keep providers updated. And then the VPR research working group has been on reproductive health is being developed, and we actually have a strategic planning event on May 23rd. So I invite any of you who are interested in doing this type of research to join us. And then the Scholar Strategy Network, we have a great Utah chapter that is working with National Scholar Strategy Network to kind of bridge that gap between academic scholars and policy engagement and helping us navigate some of those complexities and confusions that maybe come out of being an employee at the university. And then finally, I would like to direct you to the Ascent website, where we really try to keep up-to-date information and resources. We have put together these dot phrases on abortion access. So if you ever have patients or there's a provider one, if you want information for yourself, you can access those there, and it gives you up-to-date kind of real-time information on what's going on and what other resources are. So thank you so much. I appreciate the time and happy to chat more.
Thank you, Dr. Mihalopoulos and Dr. Sanders. In the interest of time, if any of you have questions for either of them, they'll be around, and please feel free to talk to them. Let's take a 20-minute break, but please vote on the posters. I have to confess, I didn't realize until just moments ago that there, besides moving things around on that Qualtrics thing, there's apparently an arrow at the bottom that I have to find, you all have to find, and we have to push, because just moving things around doesn't count. Got to hit submit. So please visit the posters. Please be back here at 5 minutes until 4, and please hit the submit button.
Okay, I'm going to get a head start. So welcome back, everyone. I have the absolute pleasure of introducing our keynote speaker for our 2024 symposium. Last year, we had Dr. Pauline Mackey come be our keynote speaker, but we are very lucky to have Dr. Lisa Larkin. Dr. Lisa Larkin is a board-certified internist and midlife women's health expert who has practiced in both academia and private practice since 1991 in Cincinnati, Ohio. She did her medical training at both Yale University and University of Chicago. Dr. Larkin's professional mission is to raise the standard of care for women across the lifespan, and I can attest to this. She's a trailblazer and innovator in our field, and have looked up to her since the first time we met back in 2017. She is the founder and CEO of Miss Medicine, a national healthcare organization she founded to address the gaps in midlife women care, through innovation in clinical care delivery and through women's health clinician education. Today, Miss Medicine is a clinical network of female-focused concierge providers and physicians who are practicing in 10 states across the nation. Miss Medicine also supports a virtual education platform called Provider Hers that offers weekly women's health education to clinicians across the U.S. I personally attend these monthly or Monday night discussions regularly. So please let me know if you have any questions and if you would like to be a part of this group. It is continuously expanding. She is also considered a national expert in menopause medicine or management, sexual medicine, breast cancer risk assessment, prevention, and genetics. Dr. Larkin is a well-known educator and lectures frequently at physician CME programs and consumer education events on women's health topics. She actually has to fly out tonight to present at ACOG at 6:30 a.m. in the morning. I must add that she's basically a medical celebrity and has been in the news almost every week since the beginning of this year. Dr. Larkin has been on the board of trustees of the Menopause Society since 2018, serving as treasurer, then scientific program chair of the 2023 annual meeting, and now as president of the Menopause Society. Dr. Larkin formerly served as associate professor and division director of midlife women's health and primary care at the University of Cincinnati College of Medicine and is a director of the University of Cincinnati Women's Health Center. She is a fellow of the American College of Physicians, a Menopause Society certified practitioner, a fellow and a past member of ISHWISH, the International Society for the Study of Women's Sexual Health. Her bio kept on going, but I had to cut it short. So you know why we chose her as this year's symposium. Without any further delay, everyone, please welcome Dr. Lisa Larkin.
Okay, well, thank you very much. That was way too long, but I'm very grateful to be here today. This is a topic that is near and dear to my heart, and I'm really happy to be here. So these are my disclosures, and you can see I do a lot of consulting in the menopause space. I have no disclosures in the breast or the genetic space, nothing to do with this talk at all. These are our objectives. Now, what you don't know about me is I always have too many slides and I talk fast. And so in the interest of time, I won't read all of these, but they're in your syllabus. So breast cancer. I think all of us as females worry about breast cancer. I'm actually a breast cancer survivor now, just hit 10 years. And our patients worry about breast cancer. And I think our patients actually hear this statistic all the time, this 1 in 8, and this 12% lifetime risk of developing breast cancer. And I think it's important for our patients to know that. They worry about that. But what's really important is that that doesn't mean that's the risk of the individual patient sitting in front of you. And what I hope to convey to you today is that we need to think about breast cancer risk individually in the same way we think of cardiovascular risk. So I'm a clinician. I still see a lot of patients. I do both primary care and consultative women's health. And I like to use patient cases as an example. So I have 2 cases to talk to you about today. These are very typical patients for me. This is Liz, and I bet these are typical patients for you. So she's worried about breast cancer. She's 52. She doesn't get much medical care. This is the age when I would argue that women fall through the cracks. They're done with childbearing. They don't really have significant health issues. They're not seeing their OBGYN very much anymore. They're not really seeing their internist yet, except maybe for a sinus infection. And I would argue, and this is why I'm in the space I am, that this is the most important time where we can actually impact how a woman is going to age if we actually had more opportunities to care for her in a really evidence-based way during this midlife. So this is a typical patient, right? She doesn't come in very often. She's getting her mammogram. She's postmenopausal for 2 years. She has mild hot flashes. She hears negative things about hormones, and so she never even talked to anyone about that. On her mammogram, she knows she has extremely dense breasts, and she doesn't take any medications. And yes, she has a mother who died of ovarian cancer at age 80. Catherine also worried about breast cancer. She's 56. She has high cholesterol and hypertension that's well controlled. She's also postmenopausal for 2 years with mild hot flashes. She also had a negative mammogram 6 months ago. She also has extremely dense breasts. She has no family history of breast cancer or ovarian cancer or any cancer in 3 generations. And so these 2 women are both worried about breast cancer, but their risk of developing breast cancer is not the same. And yet we continue to treat women the same, right? And that's really the point of this discussion today, is really hopefully to get you to start thinking about individualized and precision care for women. And why do they have different risks? Because there's lots of things that influence risk for developing breast cancer. So some related to genetics, and then others related to what we call modifiable and non-modifiable risk factors. And you can see it's just a smattering of women that I put here, some who carry hereditary cancer mutations, a woman who had ALH on a previous biopsy. And then you see that risk can be all over the map, but the risk is not the same. And I want you to step back again and think about how we approach cardiovascular disease and realize that we're not approaching breast cancer the same way. Everyone knows about what risk factors are for heart disease. We actually do a pretty good job of educating consumers about if they have risks for heart disease, how to modify those risks. We do a good job in clinical medicine of estimating the risk. ASCVD risk score, it's common, we use it, we talk about their risk of developing heart disease, and we really work to reduce patients' risk. We educate them about all the things that they need to do. The way that we're approaching breast cancer is not that. We're telling women just to get their annual mammogram. That's about all primary care doctors are doing still right now, right? Get your annual mammogram. That's what our metrics are that we're scoring scored on, right? But that really isn't addressing individual risk. It's doing nothing for prevention. And I would say in the cardiovascular space, that would be like just telling our patients to get an annual stress test and not addressing risk, right? It's when women go to get their mammogram, they're just waiting to get called for that abnormal mammogram that says, you need a biopsy, we think you have breast cancer. And this, I think, is a great slide from my dear friend and colleague, Dawn Musalem, who's at the Mayo in Jacksonville. And really, it's, we continue to just focus on breast health for waiting until someone has largely a breast cancer diagnosis without addressing individual risk and then working towards prevention in the same way we do for cardiovascular disease. So for those of us who see women, which I think we all do, right? We know that midlife is the time when women are worried about getting breast cancer, and you can see why. If you look at the incidence of breast cancer, it really is the peak between 45 and 65. And again, this is when women have the least points of contact with healthcare. But again, the incidence of breast cancer does go up over the course of the entire lifespan. And what about mammography? So this is a really big topic right now. What we're doing with mammography is we're just using age as our criteria for screening. We're doing nothing with taking into account individual risk. This is not precision medicine right now. We're just saying it's an age-based thing. It's not based on actually figuring out risk or ethnicity. And what you may have heard, and I just updated these slides, is just last week, the U.S. Preventative Services Task Force came out again with the final recommendation. And finally, at least, the U.S. Preventative Services Task Force has come into line with the age at which we start mammograms being 40, at age 40, which I think is good news for women. But still, there's just differences among all of the professional organizations. And I would tell you, you have to ask, how can we all be looking at the same data from mammography to come up with guidelines? And why do professional organizations all still have different guidelines when there's millions and millions of data points on how good mammography is, right? I would argue it's because we're just trying to homogenize all women, right? So the data really doesn't show us exactly what we need to know. And so we end up with these disparate guidelines. You can see that the interval is the big thing. The U.S. Preventative Services Task Force is still recommending every 2 years, whereas the other organizations, it's annually. And then there's really debate about when to stop. I would tell you later in the talk, we're going to talk about the differences in these guidelines as it relates to what we do with women with elevated breast density, which also makes these guidelines now really confusing again. And what about mammography? Well, it's not a perfect test. We all know this. It is the only test we're using right now that's demonstrated to decrease mortality, but it's really limited. 20% interval cancer detection rate. That means that these women who are up to date on their mammogram may have a cancer detected in between their mammograms. And why is that? Because the false negative rate is high. It's 4 to 24%, and it really relates to breast density, which is why you're now hearing a lot of buzz that we're going to talk about and recommendations for women who have dense breasts to get enhanced screening. The other thing is the positive predictive value of mammography is low. That means that false positives are common. So we all know that women are getting called back. We all see this, right? The chance of a false positive with one mammogram is 7 to 12%. 50% of women will have at least one false positive recall. 17% will get that false positive short interval follow-up, and 11% will have a false positive biopsy recommendation. So again, mammography is what we're using, but it is certainly not a perfect test. And I love to say it this way, which is that it's great when we see something on mammography, right? It's the iceberg that we can actually see. But the problem with mammography is we're not seeing all the things that we need to see, worse in women with dense breasts. And this is why we have interval cancers detected. And what we know is that the mean time for a breast cancer to grow from 1 to 2 centimeters is 1.7 years. So when you have a woman who has a breast cancer that's above 2 centimeters, like I did 6 months after having a negative mammogram, you know that that breast cancer was there on at least 1 and maybe 2 prior mammograms. We just couldn't see it. What we know is that, again, we said this 20 to 33% of cancers are detected between screening studies, either symptomatically or by another modality. And what about racial disparities? We know that this exists. We know that African-American women have a higher chance of having breast cancer diagnosed at an advanced stage. 53% of African American women have tumors at diagnosis over 2 centimeters compared to 43% of white women. And we know we're going to talk about that there's also the difference in triple negative, the prevalence of triple negative. So you can see here, African Americans, 24% of the time have triple negative disease, and we know that that's the bad actor, compared to 12% of white women. We don't exactly understand these racial disparities and why right now, but they clearly exist. And mammography, I just told you it's not a perfect test. It's certainly what we need to be doing now, because why? We need to detect cancer early, because cancer size at diagnosis directly correlates with survival. And so we want to be really thinking proactively. Who are our high-risk patients? And really, again, talking about who meets criteria for enhanced screening. And what about racial disparity in breast cancer mortality? Well, the good news is if you look between 1999, and this goes only up to 2014, that the trend is down. We do see decreasing mortality, but if you look at the top with African American, we see across the board, their mortality has not come down. It's higher consistently above all other races and ethnicities. And again, this is really something that requires more investigation, and we need to do better. This just recently came out, and I think that this is really important to talk about, which is we're now seeing increased incidence in really our much younger patients with breast cancer. So this is significant and new, and anyone who wants to attribute all of the breast cancer to the use of postmenopausal hormone therapy really should take a look at this slide, because it's clearly not the only thing that's going on. If you look starting in 2016, which was long after the WHI and the decline in use of menopausal hormone therapy, and again, 20 to 49-year-old women are not those who are using postmenopausal hormone therapy anyway, that there's that very significant, dramatic, going from an annual percentage change of 0.24 up to 3.76 in terms of the incidence of breast cancer in our younger patients. And again, we really don't understand this, but I'm sure you can understand that with this, right, mammography starting at age 40 in women who are still of reproductive age, they typically have more increased breast density, so mammography isn't as great a test, and they actually were continuing to see earlier and earlier breast cancer. So my argument today with this talk is that we want to have precision medicine, and what we want to try to figure out is what is the individual patient's risk of breast cancer sitting in front of you? How can we do a better job personalizing risk and talking about more personalized risk reducing strategies? And I would tell you that, you know, again, mammography is important and early detection is important, but wouldn't it be better, and shouldn't we really be trying to do what we do with cardiovascular disease, which is really preventing breast cancer, right? And I would say we really have to identify those women at high risk if we're going to prevent breast cancer. And what do we know? We're failing to identify the majority of women who carry hereditary cancer mutations that put them at significant risk. And we're also failing to identify those women who don't carry a mutation but are at high risk for non-genetic reasons. And this is the point of this talk. I'm hoping by the end of this, you have a sense of how you might approach assessing risk in your practice. So I've been kind of giving this talk or talking about risk assessment and doing this work really for the last 7-8 years now. It's great to see, you know, menopause is having a moment because of all of the, you know, social media celebrities that are now becoming menopausal and have really started to drive change. But I think this was really very significant because this was the first time with Olivia Munn's diagnosis that I had anyone ever seen on any of the major news outlets talking about breast cancer risk assessment. I've been kind of shouting it for the trees from the trees for years, but I think that this may be, just like with menopause, the beginning of kind of a sea change, and where we're really going to be having women who start to ask questions. What's my individual risk? So how do we assess risk? Well, there's non-modifiable risk factors, and these are the genetics. Again, remember, your patients still believe that if they don't have a family history of breast cancer, that their risk is relatively low. Remember, you've got to educate them that that's not the case. 75% of breast cancers occur in women who do not carry any genetic reason to have their breast cancer. 5 to 10% have BRCA mutations. 10 to 15% carry other mutations or occur in family clusters. But again, it's more common than not for a woman to develop breast cancer that does not have a family history. We also know reproductive factors, right? So early puberty, specifically women who are under age 12, and we're seeing that more and more now. For every 1 year delay in menarche, risk goes down. late menopause over age 55, not having children has a relative risk of 1.2 to 1.7, and then age at first live birth. So having your first child under age 30 is protective. The older you are when you have your first birth increases your risk, and there's no change in risk with infertility. And I just had another case this week, and I use this slide to make the point, I hope, to every single one of you in the room, that if you have a patient sitting in front of you who's had a prior biopsy and they don't remember what the pathology is, I really encourage you to go back and look. I say I have one case a year. I've already had 2 cases this year where I've gone back and looked at the pathology. I had one this week where the patient had ADH 10 years ago. The patient this week for me was a woman who she's 56 now. At 46, she had a breast reduction, completely just a breast reduction on both sides, and the path came back with an area of ADH in one of her breasts. She saw the plastic surgeon, she saw a breast surgeon in follow-up to that. No one talked to her about really what her lifetime risk was with that ADH diagnosis, and no one had even been doing enhanced screening, never mind talking to her about chemo prevention. So again, please go back and look at the pathology if you can find it, because ADH confers a lifetime risk of 35%. LCIS, again, relative risk of 7 to 11. What I want you to see on the right-hand side is the one thing there, if you can look at, and it's hard to see really, but the bottom 2 lines are no prior biopsy compared to a non-proliferative, so a biopsy that really is considered insignificant. You can see that for some reason, women who undergo biopsies, even if they're benign, still are at increased risk. And you may know this is one of the questions when we do the Gale model is, again, any prior biopsy confers increased risk, but we really want to find those ones that are LCIS and ADH and ALH. Okay, breast density. The good news is I predict, how many of you have had patients coming in asking you about breast density now and what to do with it? Okay, few of you. So breast density is really all the buzz now, and I'll give you some slides as to why, but 50% of the population now, 4 categories of breast density, A, B, C, D, replaced by fat, scattered fibroglandular density, heterogeneously dense, and extremely dense. Women are getting density information already in their mammogram reports. I can tell you when I do community-based lectures over the years, women, when I would ask them if anyone knew their breast density, no one would raise their hand. Now it's becoming more and more common. But still, women don't understand, and I will tell you, doctors don't know what to do with the information exactly yet, too. When women say, yeah, I've been told I have increased breast density, but it's kind of like saying, you have blue eyes. Like, what do you do with that information exactly? Women don't really have a great understanding of how that confers increased risk. So certainly we talked about increased breast density decreases the sensitivity of mammography, but it also confers increased risk. So if you look here, if we use fatty breasts as a relative risk of 1, you can see that the scoring, so it depends on the percent of glandular tissue. And I would comment that density is not something that you as a clinician can tell based on exam. It's not something patients can tell. It really is, they need to have their first mammogram to get an accurate sense of their breast density. And depending on their percent of it's glandular tissue compared to fat, and you can see the one all the way at the right. So that is almost entirely glandular tissue. We know that because it's white. You don't see a lot of black. Fat shows up as black on mammograms, and it confers a relative risk of 5.3. So again, breast density is really a significant risk factor, obviously not modifiable. And what about modifiable risk factors? So I'm glad I followed some of the talks today, because actually this is good to follow up on this. So lifestyle matters. As I mentioned, we do a great job talking to patients about cardiovascular risk and lifestyle. We don't do it at all, or very little still. It's really not. I would really like to see a national messaging campaign, because I really believe that midlife women would be more motivated to do the lifestyle changes that they need to do if they really understood their risk for breast cancer, because they just still, at midlife, put heart disease like 25 years down the road, and they're not very motivated. So what do we know about diet? Well, there's lots of epidemiologic studies. The bottom line is more cruciferous vegetables, less animal protein, moving more towards a Mediterranean diet. The data is overwhelmingly clear that it decreases breast cancer incidence and decreases recurrence in women who have breast cancer. And the data is compelling. And what I point out here is that really, if we look at risk factors for cardiovascular disease and we look at risk factors for breast cancer, you can see that there's huge overlap. And again, I think this is an opportunity to talk to our patients, again, and remind them that what they're doing that's good to reduce their risk of diabetes and heart disease also is decreasing their risk of breast cancer. This big trial from the Women's Health Initiative, so this was the diet arm of the WHI, so this was almost 50,000 people. This was really a simple arm. This was women were either eat regularly or they were told to just try to have a low-fat diet. It wasn't more aggressive than that. And you can see that breast cancer mortality was reduced 15% just by making that small change, right? 15% reduction in all-cause mortality with a simple dietary change. And what about exercise? Again, the data is overwhelmingly clear. Again, exercise is so important for so many things, but it also decreases breast cancer incidence and it decreases breast cancer recurrence in breast cancer survivors. So as part of survivorship, really, we should be talking to our patients, but also, again, for prevention strategies. And what about weight? So again, this is a huge, big deal. We heard some about that now, but in terms of incidence of developing breast cancer, it's really, really important that we talk to our patients about weight. So obviously you can see a meta-analysis with weight reduction 0.82 in the WHI in women who lost weight. It was 0.88 in the Nurses Health Study, 0.77. And the data is very clear in women who undergo bariatric surgery that they have a reduced risk of developing breast cancer. What about alcohol? This is my favorite thing to talk about, or one of my favorite things to talk about, because again, women do not understand that alcohol is associated with breast cancer risk. I don't know about you, but in my practice, it's often my midlife women who start to drink more, right? Their kids are away at school, they're empty nesters, their career is often hitting their peak, they're socializing more, they have more business dinners, and they're drinking more. And again, this is really a significant thing. I would tell you, there's really, those of us that look at this data would tell you there's really no safe alcohol. You know, we used to say that it was 1 drink a day for heart protection. I can tell you that that's not really based in good science. You really need very little red wine, about a half a glass a day, so about 3 drinks a week to get the heart protection. And so really when I talk to patients, again, I think telling them they can't drink at all is often hard, but I try to get them to be very mindful and try to get to 3 drinks a week, but it would be better if they completely abstained. What we know is, again, in the US, this is a big deal. Women are drinking, and we think now epidemiologically that it accounts for about 12% of breast cancer. It increases the risk of developing breast cancer in pre- and postmenopausal women. And again, we think about alcohol use all across the lifespan. So this is really important to be talking to your younger patients, college age patients as well. And so again, discuss alcohol. And then what about soy? So this comes up all the time in the survivorship arena, but I can tell you that there's pretty clear data, and I love to talk about this, that moderate consumption of soy is safe for both survivors, and we really do not believe that it increases risk. We really encourage a diet that's high in soy. We know in the Asian population, soy consumption, really is associated with lower risk. We think that that's earlier consumption of soy. When Asians come to the US and are on an American diet, they very quickly get back up to American rates of breast cancer. And what about prevention? So again, I talked earlier use in the Asian population. This data comes from a reduction in breast cancer incidence. And again, use post-diagnosis reduced mortality and decreased recurrence rate. And again, it didn't matter what they were on for anti-hormone therapy. So lifestyle is the silver bullet. We really need to talk to our patients about this. I love this slide from the World Cancer Research Fund on the right. I mean, if you think about this, right, we know the number 250,000 cases of breast cancer estimating in the United States per year. The data really suggests if we could get our patients having a healthy diet, exercising, maintaining an ideal body weight, not smoking, and really minimizing alcohol, we could prevent 33% of breast cancers and even more colorectal cancers than that. So it's really important. And what about risk factors? And I just want to point out here, and again, we're going to talk a little bit and how I approach patients when it comes to menopausal hormone therapy and how I talk to them about breast cancer risk. I want you to see from the WHI on the upper right with hormone therapy, and that's the estrogen plus progestin arm. The relative risk was 1.2, but you can see my white arrows there that it just correlates. If we look at obesity or a high-fat diet or alcohol consumption, again, when you have a patient that comes in and says, I will never go on hormone therapy because it causes breast cancer, you really want to talk to them about the other things that are associated with breast cancer, particularly being overweight or obese, a high-fat diet, or drinking alcohol, because those are modifiable risk factors. And again, you want to make sure that, again, they're not over-dramatizing hormone therapy as the big, bad, evil thing when they're have all these other modifiable risk factors that they can adjust. Okay, so switching gears. How do I think about breast cancer risk assessment in my practice? So I think of 4 buckets. And we're really going to focus on the 2. So if you can think about anything, I want you to think about how you would do better. We all are not doing well at identifying our hereditary mutation carriers, and then those individuals who are really at the highest risk, which is a lifetime risk of greater than 20%. So how do I go about doing this in my clinical practice? Well, I want to set the stage. That some important statistics. So 1 in 500 women in the United States carries a genetic mutation, and that's much higher, 1 in 40 in Ashkenazi Jewish individuals. We need to be thinking about this in practice. And these NCCN guidelines are here. And again, this is in the document that I sent out. So you have these. Again, what you want to think about when you have the patient in front of you. And again, the problem with healthcare delivery, right, is visits are short. So we don't often or all the time do a great job of updating family history or talking about this again. But what you want to look for is young incidence of breast or ovarian cancer, pancreatic cancer, Ashkenazi Jewish descent, male breast cancer. Look for flavors of cancer. And then again, if you are not comfortable really doing an assessment in practice or don't have the resources, looking for a way to screen your patients to refer them to a genetic counselor. I do genetic testing in my office, which I can talk about. But again, you really want to think about this. Because what we know, and this is a really well done study, 1 in 4 women sitting in front of us meets criteria based on that. I actually did several breast cancer, this is 5 years ago now, breast cancer consumer events in my community in Cincinnati. And I got exactly the same data, which is about 25% of the women who came to these events had elevated breast cancer risk above 20% when I did their Tyrer-Cuzick, and 1 in 4 of them met criteria for genetic testing, and none of them had ever been assessed for that before. And so this was a study looking at about 4,000 patients who were screened with a family history questionnaire. Of those, almost 1,000 or 24% met those criteria for genetic testing. 813 were offered testing, but only 165 completed testing, so 4%. And in that 165, 9 out of 165 or 5.5% had a mutation. Can you imagine how many we just missed? Because if 903 met criteria, we only tested 165, we missed a huge number of women, and this is in a setting where we were doing screening. So we have to get better at this. I can tell you that there's barriers, and what we know is that, again, I use this paper screener in my office. We've played around with some technology, sending patients through text messages, screeners that they can complete before their visit. But that's been cumbersome for us to operationalize. So we went back to this paper screener that I do at every time a patient comes in for their physical or their well-woman exam. But what we know is that the majority of clinicians just aren't able to do this, or they don't have the infrastructure or the staff. And so it's really just time consuming and difficult to operationalize. And so this is part of the barrier to missing these people who carry, who meet criteria and who should get genetic testing. And what we know is that it extends beyond breast cancer, right? If you look, it's ovarian, breast, colorectal, endometrial, pancreatic, and prostate. And look at the prevalence. I mean, if you look, 19% of people who have pancreatic cancer actually carry a mutation. It's 18 to 24% of women with ovarian cancer carry a mutation. And just depending on the tumor type, you can see the prevalence there for breast cancer. And so again, if we think about this and we know the prevalence of these cancers in the United States, you can see that if we did a better job identifying these mutation carriers, we could prevent 60,000 cases of cancer in the United States per year. And that's preventing cancer. That's not detecting it early. And unfortunately, what the data really shows is that we are only right now identifying about 10% of women who carry a mutation. We've got to do better, and we need to think about how we can use technology to improve that. And so when we go back to our patient and think about Liz, she had the mother who had ovarian cancer at age 80. She meets criteria for testing, and I can tell you she's the patient who gets missed, right? Her mother was older at death. Family history is one of those things that doesn't get re-updated, and she was never offered testing. But lo and behold, when she does get testing, she's BRCA1. And so this is Liz. So she has a lifetime estimated risk of 72% for breast cancer, 44% risk of ovarian cancer. This is probably the most impactful thing you can ever do, is make this diagnosis for this patient. Why? Because you can prevent her breast cancer, right? You can at least do enhanced screening. You could talk about all of the important things for risk reducing measures, certainly lifestyle, but she's really someone you would talk about chemo prevention for, risk reducing surgeries. She clearly should have discussions about removing her ovaries and or consideration of prophylactic mastectomies. And then the other thing, this is about identifying mutation carriers in her siblings and her children. And so this is a really big deal, and we need to do better at this. But let's switch gears and go back to Catherine. So she has no family history in 3 generations, so she doesn't meet NCCN guidelines for testing. What I would tell you is I'm a huge advocate of this. There's a whole group of us in the genetic space that we really are very passionate about this, is that you can make a case for population genetic testing now. So the cost of genetic testing and doing these panels has come down dramatically. I was diagnosed with breast cancer at 49, 10 years ago. And so when I had genetic testing, I paid $4,000 out of pocket for it. Now to do hereditary cancer, an 84 gene panel, which I do in my office, it's $250 cash, and you only have to do it one time. You can make an argument, I believe, that because we're missing so many women and because collecting family history has really been shown to be ineffective, that we should start looking at what the cost-benefit analysis is of population genetic testing. This is the other reason that I'm really for this too. So this is thinking about all of your breast cancer patients, right? So I think there is data to support testing all breast cancer patients, regardless of the age that they are when they have breast cancer. Because what you want to see here, and you don't have to look at all of the mutations, but look at generally the blue and the yellow. They're relatively the same number of patients with mutations. And what this was is 1,959 breast cancer patients. All of them had panel testing for 80 genes. They went back and did family history. Half of them met criteria for testing, half didn't. And what you look is the number of mutations identified was exactly the same, whether or not they met criteria or didn't. The prevalence of a pathogenic mutation was 8.2 to 9.6, regardless if they met family history, right? So family history clearly is not perfect. We should be thinking about, I think, population testing, but at least testing all of our breast cancer patients. Okay, so moving to risk assessment. How do I do this? So there's a lot of models out there. I can tell you the 2 that I use. So I use the Gale model and I use the Tyrer-Cuzick version 8, and they're very different, and they give different results. And I'm going to show you with these patient examples how we calculate this. The reason I like the Tyrer-Cuzick the best is because it takes into consideration all of the things that you see at the left. So it takes reproductive factors into consideration. It takes weight, biometrics, BMI. It incorporates breast density, it incorporates prior biopsy information, and it takes a 3-generation family history. And so again, this will often be much higher than doing a Gale model, but I'm going to show you how I use this with patients. So the Gale model, if you only do one thing, because you don't have time to do the Tyrer-Cuzick, but I would argue that if you get used to doing the Tyrer-Cuzick, you can do it really fast and it's really easy to do. But at the very least, the Gale model is 5 questions. It's easy to do. It takes 1 minute, and it really estimates lifetime risk of breast cancer in women over the age of 35. Now, the problem with it, in my opinion, it does not take into consideration biometrics at all. It doesn't take into consideration multi-generational family history. It only takes 1 generation of family history. But most importantly, it doesn't take into consideration breast density. How does that compare to the Tyrer-Cuzick? So this I will tell you on my physicals, I pull this up on the screen with patients and I do it with them. And the reason I do that is I show them how I'm entering the data. And then when I get the results, I play around with the data. I show them what a change in breast density does. I show them what a change in body weight does. I show them what family history does and does not do to their calculated risk. And it's really impactful, I think, really with the weight. The one thing that the Tyrer-Cuzick does not take into consideration yet, but I understand it's something they're working to get the data to actually incorporate, is alcohol consumption. But again, these are the two that I do with patients. And if we go back to Catherine and we talk about doing this with her, you can see I put the Gale model results up top and the Tyrer-Cuzick down below, and you can see they give different results. But what both of them are doing is comparing what you're calculating the patient's risk is calculated to be compared to the population. So you can see that the population risk for this patient at 56 years old is 11%. And you look at how that compares to her lifetime risk of 18%, which is calculated by the Gale model, but 23.4% when you use the Tyrer-Cuzick model. So this is a patient who hits that 20% lifetime risk calculation and meets criteria for enhanced screening. So what are the current guidelines? So we're going to talk about how these are evolving right now because it's kind of a hot mess. But the guidelines really to think about are patients who have that lifetime breast cancer risk of above 20%. And so I do this all the time in practice. So when I get a patient who has a 20%, I'm literally, when I'm ordering their breast MRI, I'm writing in their comments. Extremely dense breasts, calculated Tyrer-Cuzick version 8, 26% meets criteria so that I can get insurance coverage. And when I do that, I actually haven't had problems with that. The other criteria is, again, these patients with ADH or LCIS. I told you about the patient I just looked at her pathology and identified ADH on that. And again, she hadn't been getting enhanced screening. Anyone with a BRCA mutation, a first-degree relative who has a BRCA mutation, but the patient hasn't had testing. And the other category that we continue to miss is patients who've had chest irradiation due to Hodgkin's in their 20s. I have seen this more times than I wish I have, which is patients, when they have Hodgkin's at age 18 or 20, they get their mantle radiation, they are cancer-free and they are living their life, and they are not thinking at age 35 and 40 about breast cancer, and they need to be because they have early and very aggressive breast cancer. But what about these guidelines? So in 2019, they were really updated to talk about breast cancer survivors, and I can see this is being missed too. So again, we want to think, right, if you have a patient who has a lumpectomy, should we just be doing mammograms on that patient? What if they still have dense breasts? And the criteria were updated. Certainly anyone who had breast cancer who's a mutation carrier should be getting an annual MRI. The American College of Radiology says anyone with dense breasts and a history of breast cancer should be getting annual MRI. Anyone diagnosed with breast cancer before age 50, and if they have lobular histology. Okay, and I don't have time to talk a lot about chemo prevention, but again, this is something that patients have never heard of. I lecture in the community and I say, how many of you know that there's medications out there to reduce your risk of developing breast cancer? Nobody. I mean, I never have a patient raise their hand. And we know that this is another area where internists are not doing what they need to do. It's like a hot potato. Who owns doing chemo prevention for breast cancer? Who owns it? Who wants to manage this? OBGYNs? I'm not sure they want to manage it, right? Primary care, they're not doing risk assessment. Do they really want to manage it? And what I see is patients don't know their risks, so they're not actually ending up in high-risk screening clinics until they have cancer, or a family member has cancer, and then they end up. And so again, we're missing all of these patients. And if I can just implore, it's not hard to do. You guys can all do chemo prevention if you spend a little time just learning about it. And the guidelines really are, NCCN says it can be anyone with a Gale above 1.7. I don't use that. Most people do not. Typically, it's if they have a 5-year risk by Gale of greater than 3%, or a Tyrer-Cuzick 10-year risk greater than 5. And again, those are numbers, right? So Gale risk greater than 3%, Tyrer-Cuzick 10-year greater than 5. And so if we go back to Catherine, so she's clearly high risk. She has that 10-year of 6.1. She has a lifetime risk of 23.4. So she is absolutely a candidate for both enhanced screening and for a discussion of chemo prevention. And this is a patient, again, is in that bucket of high risk that we're kind of missing. And so how do I approach Catherine? So I really focus on lifestyle for her. and talk to her about the chemo prevention and what we should be doing with enhanced screening. But I'm going to play a game with you now, and I'm going to mix up the data. So what if I change her and I say, okay, she doesn't have extremely dense breasts. Now she has heterogeneously dense breasts. So she has category C, not category D. How does that change her risk calculation? So now all of a sudden, instead of being a lifetime risk above 20, she's a lifetime risk of 17. So she falls into that intermediate risk category. Okay, now what do you do with her, right? Is 17% really very different than 20%? I sometimes have patients who have a 19.2% lifetime risk. Is that really different than 20? Like 20 is kind of arbitrary, right? But really, what do guidelines say and what do we do with this patient? Well, so as I mentioned, patients are now getting information about their breast density in their mammogram letters that they're getting. As of September of this year, it's now nationally mandated that women get something. This is a mammogram report that my patients are getting that says women with heterogeneously dense breasts, that's category C, or extremely dense breasts, category D, should discuss with their primary care provider whether supplemental breast cancer screening with MRI with and without contrast is indicated. I can tell you, patients are going to their primary care doctors, and their primary care doctors do not know what to do with this information, and they don't want to deal with it because if they don't actually have and I'll show you why, calculated tyrocusic risk, they're not getting the MRIs covered. And so then patients are often getting $4,000 bills for their breast MRI. And again, it's really kind of hot potato. Who wants to manage this? And this is now being sent to women in their letters. And what about the American College of Radiology guidelines? So these were updated in 2021, and this is where this really comes from, which is that they are saying average risk women with dense breasts, so it's C or D, should consider it. That's why this letter is there, right? The American College of Radiology is saying they should get contrast mammogram, breast MRI, breast ultrasound, or abbreviated breast MRI, and this is where that language comes from. But not everybody agrees. So the 2023 NCCN guidelines say, and I've highlighted it there at the bottom, that heterogeneously or extremely dense breasts on mammography, they can't decide if that's enough to recommend for or against MRI screening. And then this is our patient, right, in that intermediate risk between 15 and 20%. Again, can't really say that that's the group that we should be doing breast MRI. So NCCN and ACR, they disagree, which leaves patients and clinicians, if clinicians even are looking at this data, in a quandary. And then we have what the U.S. Preventative Services Task Force just came out this week, just adding to the confusion, right? So again, we now have guidelines that are all over the map. They say that, again, women with dense breasts, they can't tell you that we should be just doing breast MRI on these women. So now the American College of Radiology is sending out letters informing patients, and we have NCCN and the U.S. Preventative Services Task Force that disagrees with those recommendations. So what are we doing? Well, I want to tell you, in my practice, which may be different than yours, and in my community, our academic health center is now doing abbreviated breast MRIs, and one of our private imaging groups is now doing abbreviated breast MRIs. I was very concerned about ordering those until about a year ago, when the data really did start to come out from trials looking at these, that the sensitivity and specificity was almost as good as the full sequence breast MRI. So the difference between an abbreviated protocol and the full protocol is you still need gadolinium, but it's about 20 minutes versus a 60-minute scan. And in my community, they're doing it for $400 or $425. And so for patients where it also comes into play, and this is how hard practicing medicine is, right? Not only do I have to talk to the patient about whether or not they should get the breast MRI, but I have to ask them about their insurance. Do you have a high deductible plan? Have you met your deductible this year? And think about, can you afford doing a $400 abbreviated breast MRI? There's all of these barriers, because patients who haven't met their deductible, even if they have insurance coverage and we do a full sequence MRI, they're going to pay $4,000 out of pocket. And so again, that if a patient gets a $4,000 bill one time for a breast MRI, they're very reluctant to do a breast MRI the next year. And I think we're kind of shooting ourselves in the foot. So there's times when I'm now recommending abbreviated breast MRI. And certainly in my patients who have that 19.1% calculated risk, I'm at least talking to them about it, because now the data looks good, that this is just as good as a full sequence breast MRI. And I'm sorry, did you miss that? Go back, you can take that. Okay, So what if she comes back with heterogeneously dense breasts and I do her tyrocusic and she comes back under 15%, right? Which I see all the time, right? I actually just did a tyrocusic on a patient with heterogeneously dense breasts, and her calculated risk, because she was thin and she had late puberty and a really early pregnancy and no family history, came in at 9%, like at low. So what if her risk doesn't come in at 17%, it comes in at 14%? Now what do we do with her? And I would tell you again that this is now NCCN says we shouldn't be doing MRIs in this patient. But again, the American College of Radiology is telling us we should. So I think it's very confusing. Okay, switching gears. Don't miss the forest for the trees. And I talk about this all the time. Midlife women are worried about breast cancer. They need to also worry about cardiovascular risk. Cardiovascular risk increases dramatically at midlife. If you calculate her ASCVD risk score, her 10-year risk of heart disease is higher than her breast cancer risk. So don't miss that we have to be talking to her about lipids and blood pressure and exercise and all of the things that she needs to be doing for both cardiovascular risk reduction and breast cancer risk reduction. Okay, now I'm going to make her even more complicated. So what if she has terrible vasomotor symptoms? She's sitting in front of you saying, I am miserable. And you calculate her risk and it's 23%. And I just told you, she meets criteria for chemo prevention, but she's miserable. So is hormone therapy an option for her? I can tell you that, again, every internist in my community, I just had a patient come in for a consult who told me she saw her internist. She wasn't this patient, but someone with severe hot flashes. And her internist literally said to her, our practice is a hormone-free practice. We don't prescribe hormones. Menopause is natural. Okay, so that's the level of understanding of menopausal hormone therapy. But again, this is a little bit of a nuanced case. This is why I think menopausal medicine, we have to really be educated about this to do a good job doing shared decision-making with our patient. But this just came out too, right? So this just came out, actually not just recently. This is the guidelines from the U.S. Preventative Services Task Force about menopausal hormone therapy, which is very clear. Menopausal hormone therapy should not be used for the primary prevention for diseases. Now, cardiovascular disease, dementia, and I can tell you there's a lot of people in the menopause space, and many of them are very active on social media right now, who are out there really poo-pooing the U.S. Preventative Services Task Force guidelines. But I think you have to remember, and this is what many of my internist colleagues rely to, right? They say, look, even the U.S. Preventative Services Task Force says that hormones are bad. Well, again, this is primary prevention. That's not our patient who's having severe vasomotor symptoms. This is not the data from the U.S. Preventative Services Task Force. So let's talk about what the Menopause Society, formerly NAMS, actually says. Well, so in the most recent position statements, it says breast cancer. A preponderance of data does not show an additive effect of underlying breast cancer risk, age, family history of breast cancer, genetic risk of breast cancer, benign breast disease, personal breast cancer risk factors, and hormone therapy use on breast cancer incidence. The patient sitting in front of me where I have this conversation, I do their risk, right? I just did this in Catherine, it's 23%. And how do I talk to her about that? I say, look, you are high risk. The biggest risk of having breast cancer is being female and having breasts, right? I can never tell a woman sitting in front of me that she has zero risk of developing breast cancer. But the conversation here is, how do we talk to a patient about what her baseline individual risk is based on her genetics and her breast density? And then what impact does hormone therapy actually have on her risk? And how do we counsel her about that? Well, this is a very good paper that came out in 2023 that I really like this. Many of you, if you look at the lipid and statin data, it has this red light, green light, yellow light kind of format. So they used it for this. How do we think about which patients are the best candidates for menopausal hormone therapy versus not? So low risk patients, these are the patients who clearly get benefit. They have symptoms, recent, they're within that 10 years of menopause, they're normal weight, normal blood pressure, physically active, have a low ASCVD risk score, and their breast cancer risk is average or low. What does that mean? Low risk for breast cancer? I'm saying it's a 5-year risk under 3%, or it's in that under 15% lifetime risk. Intermediate risk, And again, they don't define it, but I'm going to define it here for you as a 5-year risk greater than 3%. I'm going to tell you that Catherine's in here, right? So she has diabetes and hypertension and high cholesterol. Her 10-year ASCVD risk score is 9%, and she's at an elevated risk for breast cancer. So I would tell you that she falls in this bucket where really shared decision-making comes in, right? So again, 23% lifetime risk of 23%. Her ASCVD risk score is 9.8%. She falls in this bucket. So how do I talk to her then, right? So I'm telling you, she's terribly symptomatic with hot flashes. She's also a candidate for chemo prevention. I'm certainly going to be talking to her about lifestyle. I'm certainly going to be getting annual MRI on her. What do I do with hormones? Do I immediately go to non-hormonal options? I would tell you I wouldn't. You might, but this is how I talk to her about it based on the data. Breast cancer, again, biggest risk of having breast cancer is being female and having breasts. What does the data from the WHI show us? If we look at population, if I have 100 women and I follow them from age 50 to 60, they're menopausal and no one goes on hormones, there will be 3 cases of breast cancer. If I take another 100 women and they go from 50 to 60 and I put them all on hormone therapy, and really if I put them on Prempro, right, conjugated equine estrogen with medroxyprogesterone acetate. Most of us are not using that standard formulation, particularly orally right now. But if we were, I say it's worst case scenario, there would be 4 cases of breast cancer. So it's a 25% increase in breast cancer risk, but it's 1 extra case of breast cancer in 1,000 patient years. It's measurable, it's real. We have to talk about it. We can't pretend it doesn't exist. But how does that increase? How do I talk about it with this patient? And I say, if we really talk about a 20% increase, what your baseline risk is that 23%, right? If I give you 10 years of hormone therapy or more than 5, I'm going to increase it from 23% to 27%. You have to hear that with the patient, right? So it's increased. Now I want you to think about that if it's a patient who has a 9% lifetime risk and we increase it 20%. It goes from 9 to 11. It's still low. It's not 0, right? But it's not hair on fire, right? Like this patient is high risk, and depending on how symptomatic she is, if you educate her about this and she says, look, I need to manage my hot flashes right now. I'm miserable. I will talk to you about chemo prevention in the future, but like right now I'm miserable. I think you can make a case for low dose, and I would do transdermal hormones. I use transdermal most of the time. And this just came out last week as well. And this is again, I just added this, and it's obviously a busy slide, but the point being, the 50 to 59-year-old category in both the E+P and the E-only arm had lower overall mortality. And if you look at breast cancer, even in this 20-year follow-up, the data is still the same. There's a reduction of breast cancer in the E-only arm. There's a slight increase of about 20% in the E+P arm. And again, the data just continues to play out. And I will go quickly through the rest. All right, so how do I do risk assessment? Family history screener to try to find those individuals who meet criteria for genetic testing. I educate patients about their risk after I do the modeling. I talk about prevention strategies with lifestyle, and then those people that meet guidelines for enhanced screening and chemo prevention, I'm talking to them about that. And what else do we know? You heard about SNPs before. I was so excited to see that. So this is really the new thing, right? So we know all about these genes that confer increased risk. But what we've now identified is those single base pair mutations, these SNPs that you heard talk about. There's about 300 of them. When taken collectively together, they confer increased risk for breast cancer. And we're just now starting to think about how we incorporate SNP testing into our risk assessment for patients. What we know is that abnormal SNPs are much more common. They confer much less risk than people who carry mutations, significant genes. But again, how we incorporate this into our risk assessment is really coming. And what else is coming? I mean, I think this is really an exciting time in medicine, although there's so many barriers to how we have equitable healthcare and how we're going to incorporate this because of cost. I mean, there's lots of problems, but the science is really incredibly cool right now in terms of how we're using AI to improve breast cancer screening, right? So using AI to do second reads on mammograms to actually improve catching early cancer tumors to make it more efficient. And then now we're talking about breast composition. So it's not just breast density, but this is breast composition, so parenchymal complexity. And so you can see that there's people who aren't dense but have high complexity. There's people who are very dense who have low complexity. And this is really now another data point in addition to the SNPs on how we're going to bring this into our whole risk assessment model. So where I think the future is still we should be doing risk assessment. We still need to find those mutation carriers. I think we're going to have much improved risk assessment models. One of the big pushbacks about using the Tyrer-Cuzick is that it really isn't the data comes from really European white individuals. It isn't very ethnically and racially diverse. So there's a lot of concern about application of the Tyrer-Cuzick to other ethnic and races, but it's all we have right now. We're going to be using SNPs. There's really some interesting science in using cell-free DNA screening and biomarkers and proteomics, which I didn't go into, and then the radiomics and AI. So taking all of that together, what I believe in the next 10 years is we really will have a way to give a woman really what we think a pretty accurate individual risk assessment is, and we can start to move to having screening guidelines based on risk, not just based on age, because we're really not doing it right. And then we'll have a much better approach to really identify those at very high risk so we can do prevention strategies. And I think the future is bright. And so as Camille said, so education is actually my passion. And so I really do this discussion group every Monday night. It's free. It's 8 p.m. Eastern Standard Time, 8 to 9 p.m. No obligations, totally free. You just have to go in and register so we get your email. And then every Thursday, you'll get an email with the topic for the week. And then at 6 a.m. on Monday, you'll get another email with the topic for the week. If you want to jump on and join, please do. If you don't. You can come once a year. You can come once a month. You can do anything you want. It's free. And the other thing, I would really love to invite you all to attend the Menopause Society meeting in Chicago if you can. In my opinion, it's the best meeting of the year. And thank you. I'm happy to take questions. And I almost made it. And I don't know how to see the chat. So
I'm monitoring the chat. Repeat any questions for the virtual audience.
On the gadolinium? Yeah, so actually I don't think there's a lot of talk and chatter out there. I don't actually think there's enough data to raise concerns. Now, with that said, patients are concerned, right? And it's always about working with your patients. I would tell you that from my standpoint, I think there's patients we can probably get to every other year with breast MRI, right? The breast MRIs are so sensitive that, again, I think for just preventing that interval cancer detection, even every other year, this is again, right? Not evidence-based medicine. I have no guidelines to tell you to do it every other year, but I really work with patients if they're really worried about the gadolinium, or if they got that $4,000 bill and they just can't afford doing it, is really moving to the abbreviated and really doing every other year. But I hear that all the time from patients.
Thank you so much, Dr. Larkin. I do have a question I wanted to ask. So for Catherine, that last case that you presented, would you have picked Duave? I know you said transdermal is your go-to. And how would you differentiate the different types of progestins and progestogens in the market, since we have newer formulations now?
So I predict, Camille, you could answer that question very well and better than me. So Duave, how many of you know what Duave is? So Duave is a really fascinating medication, and it was off the market for a couple years, and it's been back on now for about 9 months. They had to pull it. It's a Pfizer drug. Had to pull it because of a packaging issue, not because of anything else. And I didn't realize that when you go back to the FDA, you have to actually go back with your new packaging too, not just the product. So it took a while for them to get it back on the market. But Duave is conjugated equine estrogens, which was obviously the estrogens used in the Women's Health Initiative data. And remember, in the conjugated equine estrogen arm, there was a breast cancer reduction, right? So from the WHI, I think we all really believe that medroxyprogesterone acetate, and the data supports that, is part of the breast cancer issue, right? It's not the Premarin. So we actually, there's a lot of chatter, and those of us that discuss this that think that the conjugated equine estrogens actually acts like a SERM, and that may be the way that there is breast cancer, why the data continues to show a reduced incidence of breast cancer. But so DuoVy is a combination of the conjugated equine estrogens with basodoxifene, which is a medication very similar to tamoxifen, but it is used for endometrial protection. It's really effective. So in patients who have bleeding, spotting, they're frustrated, right? There is no better option, in my opinion, for bleeding control with patients than DuoVy. But the other thing about DuoVy is, and again, you can't say this to patients, there's no data for me to actually say it decreases breast cancer incidence. In animal models, there is data that it decreases breast cancer incidence, and there's surrogate markers about decreasing breast density as a surrogate marker for breast cancer, and there are trials that are ongoing right now. But it is a good option, and again, I don't know, I would love your opinion. I mean, you're very experienced in this too, that it is something that I would talk with her about. Absolutely. I would say so. DuoVy is a good option. For me, the other thing in practice is that often you need a really small dose of estrogen to actually get someone's symptoms under control. So using a 0.025 patch, which is really less than half of the dose, the estrogenic effect that was used in the WHI, right, often is great for patients. And so you don't need a lot of estrogen to get their symptoms under control. So again, I think using low dose patch, DuoVy would be a good option. I think both of those are great. And to just end the data about the progestins, I think there is data to suggest that natural micronized progesterone, so the bioidentical, and again, patients come in, they want bioidentical. You can really talk to them about progesterone as the bioidentical, that there's data, again, that there is no increased incidence of breast cancer with that. And so again, I think the regimen that we're using is different than what was in the WHI. And I think most of us feel like, again, that 25% increase is probably less than what we're doing now. So that number I said of 3 cases to 4, I think is less than that. But I don't minimize it with patients, right? Because you never want a patient to come back. And I do say, like, we can start you on hormones or not start you on hormones. You still have breast cancer risk, like it's there. And so you never can say that the hormones are what drove the breast cancer if they come in with breast cancer, but you want to make sure that they're fully informed.
Thank you for that very thorough explanation. We have time for 1 to 2 more questions. So people in the Zoom room, if you have any questions, please feel free to write in the chat, and Dr. Digre has one.
So you keep mentioning preventive chemotherapy for people at high risk. What is that?
Oh, sorry. So I'm sorry. Yes. So in premenopausal women, we can use tamoxifen. And actually, there's lots of concern about tamoxifen causing endometrial hyperplasia and endometrial cancer and being associated with clotting risk. But actually, the data in premenopausal women is really good. In fact, it's very well tolerated, and we're now using lower dose. And there's some data in using, and I don't know what your dose you're using, but you can get away instead of using 20 milligrams every day, which is what I'm on. You can do 10 milligrams every other day, and women tolerate it incredibly well. When I talk to patients about that, so that's premenopausal, we'll start there. When I talk to patients about it who say, oh my God, I'm never taking that, I really push them to say, like, look, if you get 1 year or 2 years in, if you can try it for 90 days, like, I bet you're not going to notice it. I mean, if you can really tell them, like, look, your calculated risk is 24%. The data is if you get 5 years in, it goes to 12%. Like, that's really substantial. Like, we should try this. Like, this is the best thing that we have. So tamoxifen for premenopausal women. For postmenopausal women, again, tamoxifen is less commonly used. We typically use an aromatase inhibitor, so Arimidex, or raloxifene is often what I use a lot, right? So you're kind of getting both osteoporosis prevention and treatment with the raloxifene, and it's very well tolerated. And I don't know if you have any other pearls for people, or you do it differently.
I commonly also counsel patients on those options. So depending on if they're symptomatic and have vasomotor symptoms or arthralgias, and you pick one category versus the other. Yeah.
And I think that's the other thing about the chemo prevention or using the medication, right? There's no set time that you have to do it, right? So you do want to base it based on symptoms. Like the best time is probably not in that 52, it isn't in the 52-year-old that has severe vasomotor symptoms. I mean, you really, if you can get them through that for a couple of years, they're doing a lot of better, right? The majority of women will have resolution of their vasomotor symptoms in 7 years, not everybody. But again, if you can wait, they often do much better. But again, shared decision-making all along the way.
I think we have one question in the back
Sorry.
and then we'll come to you.
So realizing there's no such thing as immortality, has anybody looked at what high-risk women who succeed in preventing breast cancer end up getting instead and dying of? For example, a more difficult unpopular gallbladder and bile duct, all those cancers.
Yeah.
Are like treatable, or do they have higher incidence of some sort of cardiovascular?
So I can't answer that at all. Certainly, right, if we identify mutation carriers, that's a different thing. But right, breast cancer survivors do have a higher incidence of second malignancies for sure. So I don't really have the data of that, but you're 100% right. Like I say all the time to myself, because my patients have all aged with me, right? So I have a lot of 90-year-old patients right now, and it's not great being 90 all the time. Like I often say, I hope I just wake up dead, because I survived breast cancer, but I really want to wake up dead. And it's hard because with longevity and longer life expectancies brings other problems, right? Cognitive decline and dementia and frailty and so I don't have the answers.
Thank you so much. So that's the conclusion of our questions. And then we're going to invite Dr. Silver to the virtual platform. Dr. Silver, if you don't mind turning your video on.
Thank you, Camille. And thanks to everyone for attending this, another really great session. And so much thanks to the Center of Excellence in Women's Health for a terrific symposium. It's always amazing what you guys come up with, and special thanks to Dr. Larkin for really a terrific talk, not just about breast cancer screening and prevention, but really how to personalize care and how to talk to patients and have shared decision making. I want to thank everybody who was involved in this. There's way too many folks to thanks, but really special thanks to Kathleen Digre and Karen Sleep, Camille Moreno, Kirtly Jones, and Mike Varner for running the meeting and for moderating. And then a special thanks to Leanne Johnston, who really is the glue behind this and keeps the trains running on time. So thanks again for another fantastic symposium on women's health. Let's hope that we continue to have more momentum, more advocacy, more attention, more NIH funding, and it was great to see some of the stuff that's coming out. Thanks again.
Thank you.
Thanks to everybody here. Thanks to everybody here for coming today. We really appreciate all your thoughts, and please, we're going to be sending an email out that's going to give you the winners of the poster, so you know who won. Plus, we'll tell the winners that they won, and we have some post symposium handouts for you that I've already received from Diana Brixner. She said she'd be sending some information, so we'll be sending that out. And then if you have ideas of topics you'd like to hear, we would like your feedback, because we build these symposia on what people come to us and say, oh, we really need to talk on this or that, because we try to keep you up to date with what's happening in women's health and sex and gender medicine. So thanks again for coming. And thanks, Dr. Larkin, for being here and being our keynote this year. Thank you. Appreciate it.